नीरज सीरियस मत हो जाओ.
Are we ready, Ashok?
We are ready.
Okay. Good morning, everyone.
Best of luck.
Yes. Good morning, everyone. We welcome you all to the Maximum Wiroc, the Wiroc Max 2022. It's time to say to everyone, let's get Wiroc'd. With this, I hand over the proceedings of today to our President, Sir Dr. Rajesh Gandhi, to take over and introduce us to the virtual day. Ashok, please play the video.
Good morning, everybody. Respected teachers, my colleagues and friends. Let's rock. Let's Wiroc. Today is the first day of a Wiroc 2022. It's Wiroc Max 2022. Let's make it maximum. After the COVID was over, we decided that we'll have a Wiroc which has a maximum output. Let's rock. Let's start Wiroc proceedings by a virtual day. Today we are going to have on a virtual platform about 140 videos to be presented to the colleagues. They are presented by our esteemed colleagues who are specialized and super specialized in different faculties. So please join us for that. I request you to join, and thank you very much for joining right now. I hand over the proceedings to Abhijit Kale, our Organizing Secretary. Thank you.
Thank you, Dr. Gandhi, sir. Respected teachers, colleagues, and dear friends, on behalf of Bombay Orthopaedic Society and the organizing team of Wiroc Max 2022, I take this opportunity to extend a heartfelt welcome to the distinguished orthopedic surgeons who have joined these inaugural functions across the globe. The Bombay Orthopaedic Society has the highest regards for your outstanding contribution to the health and welfare of the mankind. Orthopedics issues are complex with important ramifications for our nation and our future. Today, Bombay Orthopaedic Society is recognized as a role model for the other associations in our country, and Wiroc is regarded as a benchmark of orthopedic conferences in this part of the world. As we race into the future, academic meetings will become the focus of expectations greater than even before. The nation will look to them to carry on our tradition of achievement and success. May this conference serve as a forum for exchange of scientific information and upgrade the quality of research in our country. The venue of the conference, Geo World Convention Center, is renowned not only for its grandiosity, but also for its Indian tradition and rich cultural heritage. The Bombay Orthopaedic Society would like to extend you a heartfelt welcome and an invitation to avail yourself our warm hospitality and host you at the venue. Myself, Dr. Abhijit Kale and Dr. Ashish Phadnis, my co-organizing secretary, who are working under the able leadership of Honorable President of Bombay Orthopaedic Society, Dr. Rajesh Gandhi, who is the organizing chairman of this conference, are humbled to speak before you and thank the members of Bombay Orthopaedic Society for their trust and confidence bestowing this distinct privilege upon us. As we celebrate 57 years of existence of Bombay Orthopaedic Society, our society has prospered in spite of many adversities that have come. The success of this conference is not only the responsibility of its scientific and organizing committee, but also of the attending delegates. We therefore solicit your full support and cooperation in making this a grand success. Long live Bombay Orthopaedic Society, Jai Hind. And over to Dr. Ashish Phadnis, the Organizing Secretary of Wiroc Max 2022.
Thank you very much, Abhijit, and thank you very much to Ortho TV, to Dr. Ashok Sham, Dr. Neeraj Bijlani for having helped us in such an enormous way to put everything together. And thank you very much to Dr. Gandhi for blessing this program and showing us the way. The idea was to showcase surgical procedures and surgical tips, tricks, and sort of educate the surgeon, educate our members and delegates by surgeons who physically could not be there for the conference. At the same time, also showcase some of the surgeons' surgeries so that there could be a higher interaction or a discussion during Wiroc. With this intent in mind, we have chosen faculties which are very well renowned, which have been very well published, and very respected faculty who teach very well, to take us through these videos in short snippets. It is appreciated that in a surgery which lasts for an hour or hour and a half cannot be shown in 10 minutes. And it is not a live surgery. However, to drive home certain teaching points and drive home certain technical points, some surgeries have to be recorded in clarity, and it is not possible in a live surgery. And therefore, we have chosen certain surgeries which may be common and some surgeries which are uncommon to highlight and to show our delegates and to refer to them in the future. These surgeries will be there on the viewers' YouTube channel for viewing later on. These for the registered delegates, as a link will be shared with everyone. And this will also be there for viewing today on Ortho TV, and it will remain in the archives for you to refer to later on. We have put together a very good faculty of more than 140 or 150 videos. So we hope you enjoy through the day. And I welcome our MMC observer. I welcome Michelle Parikh and all of you for this day. Thank you very much. With this, I would invite Dr. Michelle to start sharing the, start streaming the first surgery. Over to you, Dr. Michelle.
Today we have a 76-year-old patient with 86 kilogram of weight and had significant symptoms coming out of the right knee, but very moderate changes on X-ray. So if you look at the X-ray here, this is the right knee, which is the significant one, and it does appear that there is a bone on bone here. The rest of the compartment appears good. You can see that there is a complete deletion of the cartilage and there is secondary change on the femoral side. Really an ulceration on the femur. If you look, same changes, you can see this in a different sequence. And you can also see secondary changes on the tibia here. And there is a change on the femur. Now coming to the patellofemoral, the lateral cartilage is good. There is some amount of medial cartilage wear and tear, but the lateral is good. ACL, here the ACL is very good. The lateral cartilage, of course, is very good. The opposite side is in good alignment. This is in some amount of varus. I've judged it to be 5 to 7 degrees. Here is the valgus trace view. You can see that there is opening of the medial side. Although not full correction of varus, but I think that is what we are looking for, not to overcorrect this. So pre-surgery, we will start planning on the screen, whatever CT scan information we've got. Based on that, we'll make our plan first. Let's look at the screen. Now, first the tibia. We can get it here. And the slope you get 4.5 degrees. So is 5 degrees, but sorry, native slope is more than 5 degrees, but maximum you can put here is 5 degrees. Okay. So we've seen the coverage here. We've seen that it is okay here from the ACL footprint point of view. The slope here, right? Okay, let's do the femur. So the femur is size 3 according to you. Yes. So it's covering both median and lateral adequately, and within the bone here. Yeah, no overhang in the notch. Here it appears as if one bigger size can go. So let's see size 4. So this is size 4 to me appears okay because couple of millimeter of cartilage. Why did you not select size 4?
We were looking at the coverage. It looks to be like really
So I think this is best going to be judged on the table. We will check the medial and lateral boundaries,
and then
accordingly we can go. I think the balancing is, so to me 4 looks better, but we will judge on the table.
क्या हो रहा है अंकुल? ये रहने दो, अच्छा है आपके लिए।
Oh, yeah, I know. So that was Dr. Rajiv Raman demonstrating a PLC reconstruction. Michelle, you can take over with the next video.
We have a 76-year-old patient with 86 kilogram of weight and had significant symptoms coming out of the right knee. but very moderate changes on X-ray. So if you look at the X-ray here, this is the right knee, which is the significant one, and it does appear that there is a bone on bone here. The rest of the compartment appears good. You can see that there is a complete deletion of the cartilage and there is secondary change on the femoral side. Really an ulceration on the femur. If you look, same changes, you can see this in a different sequence, and you can also see secondary changes on the tibia here, and there is a change on the femur. Now coming to the patellofemoral, the lateral cartilage is good. There is some amount of medial cartilage wear and tear, but the lateral is good. ACL, here the ACL is very good. The lateral cartilage
Michelle, there is no audio to this.
क्या हो रहा है अंकल? वो रहने तो अच्छा है आपके लिए।
नहीं, तो मालूम है कैसे करना? अच्छा ये लेते हो? देखो कभी किसी में डालने का मतलब नहीं।
So pre-op varus of 5.5 degrees was correcting to 2 degrees on the table. Now I am here assessing how much the gaps can be spread using a spoon at 0 degree flexion, 45 degree flexion, 90 and 120. Here the light blue color represents looser side, the orange tighter side. We need to be between 0 and 1 millimeter on the looser side throughout. I think the most important ones are the full extension and the 90 degree flexion. Now we're trying to play with the position of the tibia and try and see if we can open up the gaps. First, I have done 1 degree varus on the tibial side, which is, I think, the normally preferred position for me. We can try and move the femur anteriorly, proximally, and achieve the gaps that we want. Here is the size of the femur, which is 4, and I was playing with that. We are increasing or decreasing the proudness of the tibial component. Overall, we are doing well with the size 4 component. Because the patient was going into slight hyperextension to begin with, I want to ensure that the extension gap is not too loose. I'm looking at the coverage of the femoral component and the tracking. The red dots are showing me the tracking of the components throughout the range of movement, both on the femur and here on the tibia. It is right in the center, which is very good. I like that. Medial lateral coverage is also good. Here we are looking at the top view to see the coverage. You want to see the green tibia on either side of the femur. You don't want edge loading anywhere. Now we are trying to check where the anterior extent of the femoral component is going to be, the anterior tide mark, by taking these dots around the anterior lip. And if you look at the figure on the top left screen, in a minute you will see it when the video, yes. Now you can see those dots are really hanging in the air. You can also see it on the bottom right figure. And therefore, it shows that the component is going to protrude. Now I'm changing to size 3 because I can't afford component protruding anteriorly. And you may remember that at the beginning with CT scan planning, that's what we were looking at, either 3 or 4. Now with 3, what is happening is that I can get the component go more posteriorly, but my flexion gap in 120 degrees is little laxer. But as I told you, 120 degrees is not very important. It's the 0 and 90 degrees. You can play with various positioning, again, the same as we did early, proudness, the flexion extension of the component. I'm increasing the flexion of the component here to try and reduce the laxity. Now I'm checking the tracking again. Certainly tracking is good, and in fact the overall coverage of the component is better with size 3. Here, the most important aspect, I am checking the ACL footprint. Those dots are showing me where the ACL is going to be. One needs to be very certain that you are not going to cut into the ACL.
Now you record. Come on, somebody. Come on.
Now we are looking at the final alignment with trial implants. We have 1.5 degree of varus, which is what we planned. This is most important that for UKR, you do not want to be in valgus. Also, we are now in about 8.5 degree of flexion, whereas we were in hyperextension to begin with. So on checking for the laxity throughout the range of movement, we are as required about 1 millimeter throughout the range.
I'll tell you second. Lift, please. Let's remove that cement. चलो कम एक सेकंड में चलो 8 रेडी रखना ये कम है थोड़ा इनसे गोज हाइट कम करो चलो रोल चल दूसरा कटा दो पंचन नगर ओके सेकंड डायमंड कटा है
Okay. Taken. Here is the post-op X-ray showing good positioning of the implants and the matching of the joint line, the tibial slope in the lateral view and the femoral component. Here is the long leg X-ray which confirms the leg is still in about 1 or 2 degree of varus.
As the longevity of our patients is increasing, hip fractures are becoming more and more common. The problem with hip fractures, especially in the elderly, is that there is relative osteopenia and there is a lot of comminution. The primary treatment of any intertrochanteric fracture is a PFN type of a fixation, whatever the age may be. But there are some cases like this one. This is a 92-year-old lady with very severe osteoporosis, 4-part comminuted fracture, and especially the entry point is all shattered. The entry point for the PFN is all shattered and there is a lot of osteoporosis. And this kind of a fracture has a chance of failure with fixation. Now, in no way are we saying that total hip replacement is the answer for a 4-part comminuted intertrochanteric fracture. No, not at all. The primary modality is fixation always and will always remain so with the intramedullary device. No question of that. But there are certain cases which are likely to fail, especially if there is a lot of comminution at the entry point. The patient has got elderly, patient is elderly with a lot of comorbidities and there is osteoporosis. So in such cases, total hip replacement is a good answer to mobilize the patient fast, because the patient has multiple comorbidities. If you fix and make the patient immobile for a few weeks, that may change the outcome dramatically. So this video is about total hip replacement with a cemented dual mobility option in comminuted intertrochanteric fracture in an elderly patient. And why especially? Because these patients have got neurological illness, multiple comorbidities, and dislocation with a primary THR may be high. So we are focusing on the surgical technique of cemented dual mobility to prevent dislocation, add more stability, and do a cemented total hip. So let me just summarize this. The initial part is that the primary fixation of intertrochanteric fracture is very successful these days with intramedullary device, PFN type, and should be the first modality of treatment. But in elderly patient with comminution, with osteoporosis, a cemented THR is a good option, but we should choose a dual mobility to prevent dislocation and instability. So now let's go to the surgical part and go to the per-op picture. So this video is about conversion of a comminuted intertrochanteric fracture in an elderly patient to a total hip replacement with dual mobility socket. The indication for doing a total hip are severe fracture comminution, osteoporosis, comminution at the entry site, and elderly patient with comorbidities. So you can see the approach is posterior, the cautery is posterior, the self-retaining is superior, and we are going through the posterior approach. Because of the trauma, there is hematoma in the muscles. That's the piriformis at the top of the trochanter. The trochanteric fracture is retracted, as you can see, anteriorly, and then the head is excised after retracting the trochanteric fragment. So it's a trans-trochanteric approach where you retract the GT and the LT fragments to remove the head, which is usually attached to the calcar portion, as you can see. Then we expose the acetabulum 360 degrees for the socket, and the plan is to do a cemented dual mobility in this elderly patient. That retractor is anterior to the acetabulum on the anterior acetabular wall. Then we take out the fat and the fibrous tissue at the base, and you can see that the self-retaining is superior, and you can see that the socket is clearly exposed and the cautery is pointing towards the transverse acetabular ligament. That's the TAL. Along with axis, we have to position our cup in terms of inclination and anteversion. Acetabular reaming is very gentle in these elderly patients. We don't have to push too much, otherwise we'll breach the medial wall and the whole game will be over. So in cemented sockets, we have to be very careful to preserve the medial wall. Just do gentle peripheral reaming. The templated size is a 47 shell, so we'll ream up to 48. remove the labrum and keep seeing the transverse acetabular ligament, because that's our main anatomical landmark to position our cup. Gentle reaming to remove the cartilage and have bleeding bone for fine interdigitation of the cement. So there you can see that nice bleeding bone is there, and we are making a few drill holes on the ilium, 1 or 2 in the ischium and in the pubis, to ensure proper interdigitation and penetration of the cement. So just to orient you once again, the sharp Homan spike is on the anterior side, the dever is on the posterior side, and the self-retaining is superior. Then we thoroughly lavage the acetabulum and keep a mop under pressure to prevent any bleeding, so as to have good interdigitation of the cement. When we're doing a cemented hip in the elderly, we have to pressurize the cement very well so that the cement interdigitation is good and the medium to long term results are satisfactory. And we'll like to hold this under pressure for 3 to 5 minutes and then put the cup, because if we put the cup when the cement is still very sticky, half of the cement comes out. So we have to keep the cement under pressure for almost 3 to 5 minutes and then put the cup. This is the metal shell of a dual mobility socket, and then we keep it under 40-degree inclination and 20-degree antiversion. Once the cement is set, we remove the holder, look for any extra cement and ensure there is no cement impingement, and we remove all the extra cement. You can see the metal shell well. Now we come to the shaft and we remove the lesser trochanteric piece because it may cause impingement. So that's removal of the lesser trochanter. The GT is being retracted with a retractor, as you can see. That's the shaft. Bone is very soft and osteoporotic, and you can see that the osteoporosis is so much that you can actually break the bone with your hand. So you have to be very careful in these patients. It does not need any kind of broaching. We just need to find the canal and then we can take our trial. So you can be just finding the canal. Now there will be no broaching. We'll just put the trial stem because the canal is so wide and osteoporotic, and we have to be very careful with these patients. Now to fix the trial, we just use a gauze piece on it so that the trial doesn't move when we are trialing. Otherwise it keeps moving and you're not sure of the stability of the whole construct. So putting a gauze piece around it helps stabilize the trial femoral implant, and we can of course remove the gauze piece later on at the end. So that stabilizes the femoral trial, and then we put our head and the bipolar trial and take a trial reduction to ensure that the limb is stable and patient will not have any kind of instability, which is very important, that the patient does not have dislocation, because the elderly patient comes with a dislocation that risks the patient, and the patient lands up in the ICU or has mortality. So you have to ensure that this is the first and the last surgery of the patient, and the patient does not have any readmission for dislocation. So you can see that the stem is proud, and we make a mark that the stem is the last mark is just above the bone, and that is the mark we need to remember for putting up our final stem. Thoroughly lavage the femur to prevent any bone cement implantation syndrome. Then put a cement restrictor. This is size 12. Elderly patients with cardiac comorbidities are at a high risk of bone cement implantation syndrome, and we need to ensure that the central venous pressure is more than 10, the patient is well hydrated, the mean BP is above 65, and we give a shot of steroid to prevent any bone cement implantation syndrome, especially when we are cementing the femur, where the chances of the cement making a big pulmonary embolus are very high. And then we put the suction tube into the femur and then gradually put in the cement with hand and not with a gun. In a younger patient, we can use a gun, but not in an elderly patient, because the risk of cement emboli are very high, and the patient may die on the table because of a cement embolus or may have a major cardiopulmonary complication. So please be careful when you are cementing in elderly. Cement with hand and keep the pressures high give a shot of steroid and keep the central venous pressure more than 10. Then cement, and you can see that we have put the stem as marked earlier in the trial above the first mark, because the stem will be proud here. It will not go deep inside because there is no trochanter. And because there is no GT and LT, we need to reference our anteversion with the leg. You can see we are 20 degrees anteverted with respect to the intraepicondylar axis of the knee, and the GT and the lesser trochanter are not there for us to take a reference for anteversion. So we have to be careful with the length of the stem, and we should not sink it too much in, otherwise the patient will have instability, and we have to be careful with the anteversion. Now we assemble the head on the poly, and you can see this simple instrument pushes the head onto the poly and locks it in, which further will go into the metal shell that we have already cemented. This is a dual mobility construct. We are not trying to promote any one particular company. This is just to highlight and share the principle of cemented dual mobility socket to prevent instability in comminuted intertrochanteric fractures in elderly, because the GT fragment is broken, the abductors are compromised, the patients have neurological problems, and elderly patients with Alzheimer's or dementia and so on. So we can use a cemented dual mobility to prevent dislocations. Now we put the final construct which we assembled on the back table. Pulse lavage thoroughly and then reduce. And we'll see that the hip will be very stable and the chances of dislocation are less with a cemented dual mobility with respect or as compared to a simple total hip or a bipolar. Now you can see that the hip is very stable in spite of the fact that GT is very fragile, the trochanters are compromised, the abductors are insufficient. Still the patient has good stability. We have not lengthened the patient, and this dual mobility works very well. We can do an uncemented dual mobility if the bone quality is good. If the bone quality is poor, as in this case, we have done a cemented dual mobility. Stable inflection, adduction, internal rotation. You can see that patient is stable even in sleep position. Now, in a younger patient, we will wire the trochanter and get it down, but an elderly patient, the bone is so fragile, so weak, so osteoporotic that we prefer ethibond sutures and repair it with the vastus lateralis along the ridge. You can see that, so it will have some kind of stability. If we put wires in elderly, they either break or impinge and cause infection. And we repair very carefully the posterior capsular structures, the piriformis, and all the external rotators. And that's the extended capsular closure. So even if the trochanter is compromised and the abductors are insufficient, the dual mobility gives us very good stability. So in the peroperative video, we did a cemented dual mobility, and this is the post-op X-ray. You can see that there is nice cementation throughout. There is no radiolucent zone either in the acetabulum or in the femur. We have chosen a longer cemented stem with good cement mantle, and you can see that the offset is restored, and this is a dual mobility option, a cemented, because the uncemented fixation in either the socket on the femur was not possible because of loss of osteoporosis in this elderly 92-year-old patient. We have chosen a cemented dual mobility to increase the stability of the patient, prevent any dislocation because the patient has neurological illness as well, and a cemented stem with restoration of offset and limb length. Most important is to prevent instability, because when the patient has instability, patient gets readmitted for dislocations, the chances of mortality are very high. So in any case, we have to prevent instability or dislocation in these elderly patients, especially post-IT conversions that we are converting to a total hip. We should use a dual mobility option. Uncemented if the bone quality is good, cemented if there is osteoporosis. So let me summarize this whole surgical exercise. First and foremost is that try and fix intertrochanteric fracture if the bone quality is good, always with intermedullary device. If there is combination osteoporosis and the entry point is shattered, then a total hip can be considered. Dual mobility option helps us to prevent instability, and we can use a cemented option if the bone quality is poor, or an uncemented option if the bone quality is good. I hope you will find this video useful. Thank you very much. Hello friends, this video is about the principles, techniques and pearls for mega prosthetic replacement of distal femur for a supracondylar fracture femur. So this lady, 75 years, presented with a neglected fracture, as you can see in the supracondylar area of the femur, and she had this fracture about 4 months back with advanced OA of the knee. So you can see there is supracondylar fracture, very low type, oblique, neglected for 4 months with advanced osteoarthrosis and also a stress fracture of the tibia. So the only way you can manage this case is by doing a mega prosthetic replacement. Now one might argue, why not fix this fracture? Because it is so low and neglected for 4 months that if you go for fixation, the lower piece is very osteoporotic and very small, one may not achieve success, and the patient can't walk with such severe arthritis. So the only way to get this patient quickly rehabilitated is to do a mega prosthetic replacement of the distal femur. Now there are 3 types of mega prosthesis distal femur type available in our country, and we don't want to promote anything, but I would like to share with you the principles of all those 3. The first is DePuy's LPS system, which is a very good system. It's got both cemented and uncemented rods. It's got an HA collar for the bone to ungrow the part from where you attach the stem. It's a rotating platform and comes in various sizes, and that's what we'll be using and we'll share with you in the surgical video that will follow this presentation. The second one is a Stryker's GMRS, which is very similar. It has got both cemented and uncemented stems and a HA collar at the end. The third is the Indian Sushrut type of a prosthesis, which has got only cemented prosthesis, and the longevity is not as good as the LPS or the Stryker GMRS system. Now, having said that, for our Indian patients with low affordability, you can use a Sushrut one, but scientifically speaking, it's either the LPS or the GMRS which are best, which will give the best long-term results. So let's go on to the surgical part now, and there we will discuss in detail all the principles of doing a distal femur mega prosthetic replacement. So let's now go to the surgical technique and the important principles of distal femur mega prosthetic replacement. So as we saw the X-ray, this is a very low supracondylar fracture of the left femur with a stress fracture of the tibia as well, very advanced osteoarthrosis, 75-year-old patient, and the only way to get her up and about is to do a distal femur tumor type replacement. Now you can see that the fracture is mobile. The range of movement of the knee is very poor, only 0 to 30, obviously because of very advanced OA of the knee. So we'll expose the distal femur. There is no tourniquet here because the incision is slightly bigger. So we don't use a tourniquet whenever we are doing a distal femur replacement. We generally don't use a tourniquet any which ways in any of the knee replacements now. So that's the gradual clearance of the periosteum of the distal femur starting medial. It's a very, very tight knee, very difficult exposure, and it's all stuck up because it's a 4-month-old and neglected fracture. So you can see I'm going very gently. This is the medial side. First removing the periosteum, the collateral attachments, all the soft tissues, and then leveraging the whole fragment from the periosteum with the help of a curved 20 millimeter osteotome. This is going inside the joint. So now we are in the tibiofemoral articulation, gradually removing the fibrous tissue with cautery and removing the stuck femur and tibia with osteophytes by the osteotome. Removing the fibrous tissue from the tibiofemoral articulation, as you can see here, there's a distal femur, then holding it gradually when it is ready to be grasped by a pointed towel clip, again going from medial to lateral, lateral to medial many times, just to tease it out gently out of all the stuck soft tissue and fibrous tissue. So we have to go medial, remove all the collateral attachments, then go posterior, remove all the capsular attachments, then come lateral, remove all the periosteum, the collateral attachments, and then only then will the distal fragment be delivered, as you can see here. So now we're removing the final periosteum, the soft tissue at the back, and there you can see the distal fragment is delivered. Very small fragment, not amenable to fixation. Fixation would not succeed in this osteoporotic lady in such a low fracture. Very hollow from inside, hardly any cancellous bone. There you can see it's a big hollow there. So better to do a distal femur replacement. Now the first step is to measure what is the size in terms of the length of the fragment. So this is 5 centimeters, and the length of the tumor replacement prosthesis minimum is 7 centimeters. So we need to resect about 1.5–2 centimeters from the distal femur. That's the most important thing. That's the first step of the operation. So you can see we are comparing the length and the width. Now this width of this tumor prosthesis is smaller, so we'll choose the bigger one in terms of the width. And the length is 7 centimeters. The resected hair is about 5.5, so we'll resect about 1.5. You can see that there is a shaft, and we are resecting 1.5 centimeters more of bone to make the total resection length 7 centimeters, which will be equal to the length of the distal femur tumor prosthesis. Then we are reaming the femoral canal. It's a bored canal, so we have to be very careful that we don't perforate. We'll be reaming till 12 millimeters and 2-3 times, and then putting in a 12 stem. The minimum stem dia is 11 and the maximum is 14. So here you can see it's not going any further because of the bow as well. So we just take a trial stem and see that it should go easily and nicely, along with 2 millimeters of cement mantle all around. Then we prepare the femur for the distal femur prosthesis, and once that is done, then we take on to the tibia. Tibia is also full of fibrous tissue. We release it medial, lateral and posterior. You can see there it's all fibrous tissue. There's a lot of scarring because of old neglected fracture and years of osteoarthrosis process. So release all the periosteum and remove the menisci and go behind the tibia so that we can put a homen so that our saw does not damage any vital structure. We put our tibial jig and remove only very thin sliver just to make a flat surface for the tibial component. So we just remove 4–5 millimeter of bone to create a flat surface, and then we can prepare it for the tibia. There you can see the tibial preparation for the rotating platform, because all distal femur prosthesis, because of higher constraint, to mitigate the constraint and loosening, all the poly is rotating platform in most revision systems and hinge systems and tumor prosthesis like this. Coming to the tibia, the stress fracture, there is a lot of sclerosis there. So we first use interlocking guide wire and then ream over it, because if we start reaming directly, we might perforate the cortex. So better to use interlock reamers, put a guide wire, then prepare it. We remove the extra bone medially, which is sclerotic on osteoarthrosis, just like a classical varus deformity. Drill holes in the tibia and the femur to have better preparation and penetration of the cement. This calcar reamer is working on the distal femur, make it a smooth surface, and there is a trial. Then there's a distal femur trial, there's a tibial trial, and we put it and put the locking mechanism so that we can trial that we are achieving full extension and we are not lengthening the limb. So it's very important to check the length of the limb at this point in time to ensure there is no lengthening, otherwise there will be stress on the femoral vessels. One shot under C-arm is very important to see that we are not too undersized or oversized on the stem. Our joint line is maintained. So all those things are very important to see. The tibial stem is right in the center. It's crossed the stress fracture, which is kind of united now. And Then we'll see the lateral view. So here again the tibial stem is in the center. It's not hitting any cortex. Those are very important things to see. Otherwise later on there is a regret that we made a mistake and did not see it. It's always better to see it while the surgery is on. Patella preparation, we always do the patella because otherwise it hurts later on. And there's the tibial preparation. Medial defect filled with 2 screws and will bypass the stress fracture with a stem. The cement restrictor goes in the femoral canal so that the cement does not go right up to the hip. It stops where just proximal to the tip of the stem. That's marking the linea aspera and the external rotation mark. You can see that there's the external rotation mark, and we will keep our stem 10 degrees external rotated to the vertical, which essentially means we'll be rotating it externally. Those are the implants: the distal femur, the proximal tibia, the polyethylene, and the locking pin, and the patella. It's very important to be well versed with these implants because more and more people are going to need them in these special situations. Then we lavage thoroughly the femur and the tibia, and after lavage we put the cement by hand. We can use a cement gun, but in elderly patients we avoid to prevent cement thromboembolism and patient mortality. So we pressurize with the thumb, and you can see there is a HA collar on the stem which will invite bone to on-grow to it and prevent loosening because of the long-term stresses on the stem. So this HA collar is very important to prevent early loosenings. Then the tibia, we cement in a very similar manner, pressurize the cement. The tibial stem is crossing the stress fracture, and then we put the final poly, lock it in, and then extend it till it sets firmly. There you can see gradual extension. The limb is not in flexion, not in hyperextension. This is a hinge joint. It will be flexed to neutral. There you can see the patellar tracking, very nice. That's the final alignment. You can see nice and straight, getting about 90 to 100 degrees of range of movement. Patellar tracking is very good. We have maintained the joint line. There is no extra residual cement, and there is a distal femur prosthesis. To critically analyze the post-op X-ray, we see that the joint line is maintained. The tibial and femoral stems are nicely centered. They are not oversized, they are not undersized. Slope is well maintained, and the stems have got good cement. The femoral stem has got good cement all around it to prevent any early loosening. So those are the important things to be observed in the post-op X-ray. So friends, I hope you found this video useful. It was to share with you the idea, the principle, the technique and the pearls for distal femur tumor replacement with advanced OA, which presents very often to us these days in various forms, various ways. So thank you very much.
Today we will discuss the technique of simple syndactyly release. This is a 2-year-old child who has simple syndactyly of the middle and ring finger. As you can see that the both adjacent digits are joined. A marking of simple syndactyly is very important. For marking, initially you mark the center of both the digits on the dorsal and the volar side. The proximal end of the center line is at the head of the metacarpal. On the volar side, again a marking is made by palpating the head of the metacarpal, and the center of the digit is marked. A marking for the center of the digit is very important because while raising the interdigitating flaps on the either digits, the flap should not cross the center. After this, a dorsal rectangular flap is marked. This flap forms the web space. It is approximately 2/3 of the length of the proximal phalanx The distal end of the flap is made concave. This helps to prevent web creep. Now, the interdigitating multiple flaps on the dorsal side are marked and also on the volar side. These multiple flaps are described as per Sommer-Ladd's technique. Laterally based rectangular flaps are created as per Buck-Gramko for separation of the nail. Volar side multiple interdigitating flaps are marked. The end point is at the metacarpophalangeal joint. Dorsal flap is elevated. This flap forms the web space. After that, the dorsal interdigitating flaps are elevated, followed by volar interdigitating flaps. While raising the volar side, take care of the neurovascular bundle on either side. The Buck-Gramko flaps which are raised are rotated and they form the lateral nail fold, as you can see here. The fingers are then released from distal to proximal by traction counter traction technique. Care is taken to protect the neurovascular bundle on the either side. The end point is the bifurcation of the neurovascular bundle. Dorsal flaps and the interdigitating flaps are sutured in their respective fingers. After this, the raw area on the dorsal surface is covered by full thickness skin graft, which is harvested from the groin. Full thickness skin graft can also be harvested from the antecubital area and from the wrist crease. The flaps are sutured with absorbable sutures. Dressing is done with the help of Bactigras and bulky dressing is given. This is the final dressing picture. Thank you.
Hello everyone, I am Dr. Parag Lad, hand surgeon practicing in Thane. I thank Organizing Committee and Scientific Committee of Wiroc Max 2022 for giving me this opportunity to present a video on ulnar collateral ligament in thumb. I am presenting a case of 28-year-old male, right hand dominant, auto driver by profession, who presented to us with injury to the left thumb due to fall from stairs. The duration of injury at the time of presentation was 15 days. Patient had pain and instability around metacarpophalangeal joint of thumb on the ulnar aspect. Whenever we suspect ulnar collateral injury to the thumb, if you feel the injury is partial or it could be just a sprain, then please do not take any stress views for such patients. I am talking about X-ray, because if you take a stress view, you are converting a partial rupture into a complete rupture. This gentleman clinically had complete and frank instability of ulnar collateral ligament injury at MCP joint. That's why I have taken a stress view, just to show how the joint opens up on the ulnar side because of complete rupture of the ligament. Another important diagnostic tools are ultrasonography and MRI. They will show us the status of ligament and duration of injury by considering the amount of fibrosis that is seen on this investigation. Once you prepare this patient and we have to examine under anesthesia, under CM control, what is the instability level. So this patient had a gross instability at MCP joint. Surgery is usually performed under regional anesthesia with tourniquet control. We take a lazy S-shaped incision on the ulnar aspect of MCP joint. The only critical structure here to keep in mind is superficial radial nerve. Injury to this nerve while doing the dissection can cause painful neuroma. Once you dissect the skin and subcutaneous tissue, we have to find out a plane between adductor aponeurosis and a capsule. And we must try to distinguish between a fibrosed injured ligament or a normal architecture of ulnar collateral ligament as shown in this video. Then you may check the instability once again, and once you do that, you have to mark the proper placement of your suture anchor under C-arm on the ulnar aspect of proximal phalanx base, because that is the site where we are going to attach our avulsed ulnar collateral ligament. There are ways to repair the ligament. The technique that I am showing is repairing of the ligament using suture anchor. We use 1.9 or 2 mm suture anchor, which is given a drill bit, and usually the threads of the anchor has needle attached. So first, as shown in the yellow arrow, that this anchor has to be confirmed under C-arm about its placement, and the point where the tip of the anchor ends, we have to drill till that level as shown in the red arrow in the C-arm, as shown in the red arrow as a picture. So this is how on the ulnar aspect of proximal phalanx base, absolute subchondral placement of anchor is to be considered. Then this is how we fix our anchor into the drill hole, and once you fix it, check whether the anchor is loosely or properly fit or not by pulling the threads of the anchor. Once the anchor is placed properly, by using the threads attached, we repair the collateral ligament. There are multiple techniques to repair the ligament. The simple is both the needles you have to draw or take out from the avulsed ligament and make a knot, thorough knot about it, and then you can incorporate surrounding soft tissues to cover the knot. Here, important point to be considered that the ankle thread knot must be cut either flush with the knife or try to cover the knot with the soft tissue, because the pointing threads of the knot can lead to irritation of the superficial radial nerve, and patient may have chronic pain in the operated site. Once you do that, this was the pre-op status under C-arm. We also again confirm the stability of ulnar collateral ligament after repair under C-arm, and we also check the placement of suture anchor. So learning objectives, pain and instability is the key feature of ulnar collateral ligament injury of the thumb. Dynamic investigation like ultrasonography or static investigation like MRI is necessary to confirm our clinical judgment, and also a good ultrasound or a good quality MRI can give us clue about either a partial or a complete rupture or acute or chronic rupture. The post-op protocol to be followed is thumb spica slab for 3 weeks, active mobilization for another 6 weeks, and after 6 weeks we start passive mobilization. After 2 months, patient is advised to perform all activities of daily living. Achieving stability by repairing the ligament improves grip strength in the hand, and options for repairing of the ligament are the simplest and technically good option is using a suture anchor, or if it is not available, we have to make a drill hole in the ulnar aspect of base of proximal phalanx and repair the ligament using non-absorbable suture material by passing through the hole. In case of chronic injury, reconstruction with the tendon graft needs to be considered. Thank you very much. I thank once again the Organizing and Scientific Committee of Wiroc Max to give me this opportunity.
Hi, good evening. This is Dr. Rohan Hapu, and I would be speaking to you on the surgical steps of posterior intraosseous nerve release. I thank Dr. Bipin Ganguly, who was there with me for the surgery, and the Wiroc team for allowing us this podium. This was a 34-year-old female with 1-year history of dull pain in the forearm. There was weakness of the finger extensors and weakness of the extensor pollicis longus. The wrist extension was okay. The sensations over the radial nerve distributions were okay. The radiographs did not show any obvious changes, and the electrophysiological studies show posterior rear interosseous nerve compression neuropathy. The patient was counseled for partial relief, and she underwent surgery for PI and release. This was done under regional block and tourniquet control. The incision for this is usually in line with the trough of the ward of 3. You can mark the lateral epicondyle and draw a straight line connecting to the radial styloid. You can see a dip depth or a depression trough here at the ward of 3. Once you go through the skin, the superficial dissection involves reaching up to the deep fascia. Right in the incision plane, you don't get a nerve, but however, there would be a cutaneous nerve a bit anterior, and we will talk about it in a bit. Once you get down to the deep fascia, that's when you start dissecting and looking for the nerve. And this nerve is the posterior cutaneous nerve of the forearm. It's usually present in the anterior flap, and it's a fairly distinct nerve that runs from anterior to posterior, and you can see it right here. Now, once you reach the deep fascia, and the deep fascia is in size, it's very easy to lose track of which interval you go, okay? So here, in this case, immediately there was a nice interval between 2 muscle planes, and we tried to go through it. However, when we reached as deep as possible, we were just unable to find anything. So the interval that you see right away is usually not the correct interval. So the correct interval is the one between the brachioradialis and the ECRL, and it's slightly anterior. Okay, so you need to retract the anterior flap, and as you pull it up on the anterior flap, you will see the interval between the ECRL and the brachioradialis. Okay. This can also be identified with the ECRL plane. Here, you could move the wrist in flexion and extension, and you can see the ECRL moving. All right. And this was the false interval. And then this anterior to the ECRL would be the correct interval. How do we know the correct interval? Because it's a fairly easy interval. You can easily get down to the depth with blunt dissection. And as you go down, you will immediately start seeing something yellow and something white. All right, and that something white typically is the superficial radial nerve. Usually the interval between the ECRL and the brachioradialis can be developed with the use of a finger or a blunt dissection using artery forceps. When you see this white structure, you start gently dissecting over it, and that's where you find the superficial radial nerve. Okay, and that's the landmark that will guide you to the posterior intraosseous nerve. Now, you can see that the SRN being dissected distally and proximally. It's the proximal dissection that's important because this will guide you down to the posterior intraosseous nerve. All right, here. Now, as you go down to proximally, you will see 3 good nerves. All right, the first one you will see would be the SRN. Then there would be the nerve to ECRV next to it. Sorry, so that's the SRN. Nerve to ECRB, and then here, right here in the posterior aspect would be the posterior intraosseous nerve. Okay. Now, once you identify the posterior intraosseous nerve, you can start dissecting bluntly over it. Here is the marking again for SRN, nerve to ECRB, and posterior intraosseous nerve. This is usually covered with a sharp ECRB tendon, and you need to release that tendon. All right. That's the first compression that we are releasing. As we elevate it over the PIN, you can release it and you find there's enough space. It's a fairly sharp tendon, so you get a good give way when you release it. Once you release the ECRB tendon, the next structure that compresses would be the supinator edge. That's the PIN going into the supinator, and that's the PIN edge. Okay, and when you do the pronation supination, you can see the way in which the PIN gets compressed. Once you release the supinator with a sharp dissection, the PIN gets completely free. Now, additionally, if there is any leash of vessels, you can cauterize it. If there is any further band, you can release it. But now you can see the PIN in the whole length from here all the way till here. Now that completes the PIN release. We release the tourniquet to see whether there is any hematoma or active bleeding. If there is, ensure that there is good coagulation. I prefer to close this wound because it's deep. I prefer to close this with a drain. The drain is usually removed in about the second day. Post-op, we just give a compression dressing with a sling. The patient can start using the hand for light work at 1 week. Weights are gradually introduced at 6 weeks. This takes us through the surgical steps for posterior intraosseous nerve release. Thank you so much.
Trigger digits have been classified into 4 stages. Grade 1, where the patient presents with only pain and A1 tenderness, but no triggering. Grade 2 is where there is triggering, which is voluntarily extendable. Grade 3 is where there is locking of the digit, which is passively correctable. And finally, grade 4, where the patient presents with a locked digit, which is uncorrectable. Sometimes one may come across a trigger finger with a very audible sound, like in this patient. Acute soft triggers can be treated with conservative management. However, one needs to rule out other conditions like tenosynovitis, in which case a sonography and further investigations may be advisable to find the cause. The various modalities of conservative treatment are warm water soaks and stretches to make sure that the flexors are gliding, limb elevation to reduce the swelling, mobilization, local ultrasonics, anti-inflammatory medications, and in some cases, local steroid injections. Now, what are the indications for a surgical intervention? Trigger digits that are unresponsive to conservative treatment, a locked trigger, patients that come with disabling symptoms that are hindering their day-to-day activities, and if there are other associated conditions like Dupuytren's contractures, tenosynovitis, or a ganglion cyst. The surgical release is done preferably under local anesthesia with a tourniquet or volant. Once the local anesthetic is instilled, the patient is asked to actively trigger the finger while the surgeon palpates and localizes the area of the trigger. Now, how do we localize the A1 pulley? The A1 pulley lies at the level of the metacarpophalangeal joint enveloping the flexor tendons. A simple way to identify it clinically is to follow the distal palmar crease, that is in line with the metacarpophalangeal joint. The digital neurovascular bundles course vertically on either side of the A1 pulley. So the best way to avoid injuring them is to carry out the dissection along the center of the digit. Once the A1 pulley is identified, we then look for the junction between the A1 pulley and the flexor tendon and start incising the A1 vertically along the center in line with the flexors. Excising a part of the A1 pulley has shown to have reduced risks of scarring, flexor tendon adhesions, and recurrence of trigger, and therefore avoiding post-operative complications. Here is a picture of a thick A1 pulley that has been excised after the release. Once the A1 pulley is released and excised, the FDS and the FDP are delivered individually and checked for proximal and distal excursion and any adhesions between the two, which may be addressed at the same time. Now, when it comes to the thumb, the orientation of the ulnar neurovascular bundle changes vastly with the position of the thumb, as is very clearly seen in this video. Trigger digits may sometimes present with other conditions as well, like this one where the patient presented with a locked trigger with early dipitance cords. In such cases, a vertical incision may be beneficial in addressing the pretendinous cords and excising them, along with the release of the A1 pulley. This patient presented with a trigger associated with a ganglion cyst over the A1 pulley. This can be diagnosed with a thorough clinical examination and further investigations like an MRI, like in this case, or a well-performed ultrasound study. Here, the ganglion was excised and the A1 pulley was released. In cases of tenosynovitis, an intraoperative ultrasound may help in identifying the extent of the pathology, like in this patient where an additional incision was made distally to excise the hypertrophic synovium. Once a trigger digit is released, the patient is asked to actively flex and extend the finger to confirm the completeness of the A1 pulley release and to ensure that there is no triggering. Isolated trigger digits are routine and with some experience, they are straightforward to deal with surgically. One must be aware of the associated conditions that may require additional surgical steps to achieve a good postoperative outcome.
Greetings from Sancheti Institute, Pune, India. This video brings to you the anterior approach for capital realignment in severe slips. We have no disclosures, no commercial support for this video. Acute on chronic severe slips are common in India in obese children, especially with low vitamin D. This case shows you bilateral slips, right side which has healed without any treatment with a large cam, and a left acute on chronic slip which presented to us. The surgery starts with a standard anterior Smith-Peterson approach. The interval between sartorius and tensor fascial lata is dissected out, protecting the lateral cutaneous femoral nerve. The rectus femoris is identified and detached from the capsule to expose the capsule. After detaching the rectus, the capsulotomy is started with an incision along the margin of the acetabulum. You can see the hematoma draining off as the capsulotomy is being done. The vertical limb of the capsulotomy goes along the neck of the femur and is sometimes extended to make an H sort of an incision. Small Homan's retractors can be placed around the neck at this time. The next step is to remove an anteriorly based 1 centimeter wedge of bone from the metaphyseal side of the neck, and as you can see, as it comes out, a gap is created shortening the neck, which relaxes the posterior retinacular vessels which supply the capital femoral epiphysis. A sharp curette is used to scrape off the metaphyseal bone, any loose fragments and remnants of the epiphyseal cartilage. This gap relaxes the vessels and allows us repositioning of the neck on the retroverted posterior head of the femur with a small maneuver which we will demonstrate subsequently. This is the piece of bone which is removed with its metaphyseal side and epiphyseal side which is demonstrated. Pictorially, as you can see, it's a triangular piece of bone with a base anterior about 1 centimeter and an apex posterior stopping just short of the posterior epiphyseal vessels which are left intact. The posterior flap, as it is called, which supplies the epiphysis, is not harmed, and this is how the wedge comes off, relaxing the vessels. With a gentle flexion, internal rotation, and then subsequent hip extension maneuver, the neck is repositioned onto the head lying posteriorly, And as the hip is extended, the head comes in front into alignment. As you can see, as the maneuver is completed at a different angle, and on C-arm, what happens when this is completed is that the neck has now aligned itself to the head, and the head, which was retroverted, has been brought in its correct position. Then guide pins are placed from the lateral cortex, central, and a 7 mm fully threaded or 32 mm threaded cancellous screw is passed, self-tapping screw, to stabilize the slip. More than one screw can be used if the neck is large enough to accommodate more screws, as is seen in this X-rays. This is the completion of the procedure with a small 1 mm drill hole in the head to demonstrate brisk bleeding, confirming vascularity to the femoral head at the end of the procedure. This is the final alignment and fixation. In our series of 26 hips, we had an 11.5% AVN rate with a 2.6% chondrolysis rate. None had implant failure or FAI. The Harris hip score was good to excellent in majority of the hips, which is about 89%, and the mean slip angle correction achieved was 29.7 degrees. If you look at literature, our results are comparable to most series where AVN rates vary from 2 to 26%. We have had no incidence of implant failure, and our technique has a very short learning curve because most pediatric orthopedic surgeons are comfortable doing anterior approaches to the hip. We believe this approach offers this advantage over a more complex safe surgical dislocation and modified Dunn's procedure with the same results. These are the references for your perusal. Thank you very much for watching this video.
Hi, I am Dr. Vijay Anandra Machikare and I am from Pune. IP joint fracture dislocation considered as a nightmare for orthopedic surgeon. So today's talk will convert this nightmare into the bliss dream. And this bliss dream is Suzuki frame. Surgical technique and inventory required. For this procedure, we required 1 mm or 1.2 mm 9-inch K-wire. It should be checked for ahead of time because many surgical centers stock only 6-inch K-wires, 2 1 mm 6-inch K-wires, 2 rubber band. If a long 9-inch K-wire is not available, then we can use 6.5 cc screw guide wire. 55-year-old male patient came with history of cricket ball injury 1 day back. X-ray showed fracture dislocation of middle finger, and this is the pre-op movement. We prefer flexor sheath block by using bupivacaine and lignocaine 10 ml so that patient can move the finger after the surgery. First of all, we mark the center of rotation of the proximal phalanx under C-arm by using K-wire. Once it is confirmed, then we mark with a marker pen. The same step is repeated on the middle phalanx and mark with a marker pen. Then we draw the line between 2 points, which should be a straight line. Then we pass a 9-inch 1 mm K wire from the center of the rotation of proximal phalanx under C-arm. Now this wire is now called as axial K wire, which is confirmed under C-arm, and in lateral X-ray it should look like a dot in the center of the rotation. Many people think that this K-wire which is used in the Suzuki frame, which will abut the extensor hood or extensor tendon while passing through the center of rotation. But in this picture we have demonstrated that this wire is passed from the center of the rotation, where it is not abutting the extensor hood or extensor tendon. Even it is away from the transverse retinacular ligament, which is important to keep the extensor tendon in center place. So safely these wires are not abutting the extensor hood or extensor compartment. Then moving on to the steps again. Then we hold the K-wire with a needle holder and bend to the 90 degree by a suction cannula, and other side is bent, and take it away from the fracture site. Then 6-inch 1 mm K wire is inserted from the center of rotation of middle phalanx under C-arm. Now this wire is called as hook wire. Then we bend this K wire to the 90-degree, one end, then other end by suction cannula, and this cannula is a very beautiful instrument for the bending of the K wire. Then 6-inch 1 mm K wire is inserted in the metaphysis of the middle phalanx, which is called as the reduction wire, which is important wire which prevents the dorsal subluxation of the middle phalanx. If you see, the reduction wire is volar to the axial wire, so that in extension axial wire presses onto the reduction wire, and that prevents the dorsal subluxation. We bend it, this wire, on the axial K wire. Then making of the hook. Distal hook is made with the help of needle holder and suction cannula. Final adjustment in the shape is done by a nose plier, and remaining wire is cut by a K wire cutter. Same U hook on other side. From the hook pin, we measure 3 cm distance on the axial K wire, which is shown in the picture. Then on the marking, needle holder is applied and wire is bent inside with the help of K wire bender. This is the first bending. Then with the nose plier, then more bending is done. Then wire is stabilized, and then second bending is done by using a suction cannula. This hooking of the proximal wire is very difficult and it needs a practice. Finally, we bend the wire with the nose plier to form a S-shaped hook. Other side, same 3 cm marking is done for hooking. If you see, the level is same. So finally 2.5 cm is the ideal distance between two hook. We use IV latex rubber as a rubber band. 1 mm is the ideal size of the rubber band. We mark 1 mm on the rubber. We cut 1 mm slice and use this rubber as a rubber traction unit between the two hooks. This is very stiff rubber and never gives you distraction in the joint. I prefer over dental rubber. This is the final frame, and this is the on table movement of the patient. If frame shows flight takeoff sign, then your frame is biomechanically correct. In post-op lateral view X-ray, the joint is reduced and there is no subluxation dorsally, and in AP view, the joint space is maintained. And in post-op 1 week, no movement till pain subside. After that, start active mobilization every 2 hourly. Wire removal after 1 month. Start vigorous physio after that. Night sprinting and full range motion after 3 months. Thank you very much.
Greetings. Today I am going to present a short pictorial and video presentation on how to do a microdiscectomy, or how I do a microdiscectomy. So let's go to the presentation. Basically, it's very important to know what is a microdiscectomy, and when you talk of a microdiscectomy, you need to understand that it is a unilateral approach with the use of a microscope, which you may use an operating loop if you are so comfortable with a loop and a headlamp. Like I said, I am comfortable with a microscope, and it's a unilateral through a small fenestration, and you just excise the herniated disc. So it's important to know the indication. It has to be one level unilateral with matching symptoms, and the indication is really, really important for it to work. So these are the 10 steps which I'm going to take you through: positioning, marking the level, how to expose, how to apply the retractor, how to expose in the depth, what to do with the flavum, how to expose the root, how to retract the root, the discectomy, and the confirmation. So positioning is very, very important for many reasons. One is to get a good access to the disc, and secondly is to do a venous decongestion, because you don't want venous and epidural bleeding. And you also need to make sure that there are no pressure points. So I use this thing, which is known as a Wilson frame, which can go into a big sort of a curve like this, because the point what I want to do is I want to create a lumbar kyphosis or obliterate the lumbar lordosis, because this opens the interlaminar spaces and therefore the amount of bony resection is less. So this is the method which I use. As you can see, there are a lot of padding which I use, silicone gel pads. You need to look after the elbows, you need to look after the eyes, most importantly, and the other pressure points like the iliac crest and the chest, because the last thing you want to do is some skin marking or skin abrasion. And another thing which you don't want to do is to have nerve palsy. So you should not pull the hands up, and you should have good support. This similar position can also be given by a knee chest position, or sometimes you need to use a 4-poster frame like this if the patient is exceedingly obese, or transverse bolsters. The principle is that the abdomen has to hang free and the interlaminar space has to be open. The second important step is marking the level. That's because this is a targeted and precise surgery, and unless you get the level right, you are going to have a wrong operation and a sure failure. So you need to study the MRI for the side and the level. And what is very important is not to give it a number like L34 or L45 or L5S1, because the radiologist may not count it the same way that you count. And what you need to do is see the counting from the last visible disc or the last plump disc at the lower end, because we are not able to count from the upper end. What I do, how I do it is, I don't do pre-op marking, I do intra-op marking, because the pre-operative markers are hazardous and can slip. So I palpate the interlaminar spaces after painting and draping completely, and I put in a needle and then use a C-arm. I don't do it earlier. And in that C-arm, I compare it to the MRI to see that my level is right. What is important is that I take a consensus, which means I look at the level, but I ask my fellows, I even ask the anesthetists, because anesthetists do know something because of pain management. And you know, if there is any doubt, I would take a further shoot. So then we are ready to start. The skin incision is an inch or less. Now we are going smaller and smaller. You center it over the disc pathology. Don't center it over the vertebra, because you need to be at the center over the disc. And the ligamentum flavum is almost slightly inferior, so you need to consider that as well. The fascia has to have a sharp incision, and you can either use a midline incision by using a small fringe to suture, or some people like a semicircular ones, which I don't like. And after that, it's a subperiosteal elevation. So it's a very beautiful, clean. So this is the incision, skin incision, and you have to make sure that there is hemostasis, because otherwise the blood will keep trickling inside. I try to use this not too strong because it damages the skin, and then I use a cautery to take the fascia out, incise the fascia sharply, and after that it's a complete subperiosteal elevation. And the subperiosteal elevation is important because that's an anatomic exposure which falls back and attaches to the lamina again, as opposed to the tubes where you forcibly open out the spaces. Then you stuff it. And this is a McCulloch retractor. This is the most important step of this operation, where we are using a McCulloch instead of a tube, or rather this is the primary one. And what we do is we have the hook which goes into the interlaminar space like this, and when it's inside you hear a popping sound and it stays straight without you having to move it. So this is the McCulloch retractor. These are the hooks which go on the medial side and the blades which come on the lateral side, and that is the distractor. So that's how it goes in. You see, there is, you put in the, when you put it, there is a pop, and it stays straight. And then you put in the one on the lateral side, and then you put in the distractor, and this distractor then opens the space, and that is your access. That is one of the most important steps for your microdiscectomy, because this is what gives you the visualization for the operation. Because what you need to do is get in a sort of sharp beam of light, the microscope. So you get the microscope on top, and you have to make sure that there's plenty of mobility so that you can move it. It's not stuck in one position. And the beam of light has to then be focused inside. The next step is the canal entry. The safe and effective canal entry is the key to your operation, because you don't want to damage the dura right in the beginning. And what I do is I enter in the midline. So there are various ways of doing it. You can also enter laterally, which is what the endoscopy guys do, because their device docks laterally. But I feel that can damage the pars and cause a pars fracture. The other thing you can do is you can go from where the ligamentum flavum comes from the superior lamina, from the L4 lamina and L4-5 disc. You can do that as well. But I like this entry. I have been taught this, and this works very well, because what happens is in the midline there is this protective pad of fat, and the disc and the dura is far away. So you enter from there safely to the opposite side. And this is what you do. First you open, there's a ligamentum flavum, you clean it up, and I use a 11 number knife in the midline, and I just use it to scratch. I don't incise, I don't push it inside. You just scratch it, and when you scratch it in the direction of the fibers, it opens, and usually there is a defect over there in the midline as well. And once you do that, under the microscope, beautifully you start seeing, as you can see, you start seeing epidural flat. And the color changes, and that is where the microscope becomes important. You then use a dura to develop that, and you push it through to the other side. You turn the dura and dissect the ligamentum flavum free from the nerve root sac at this point in time, and any adhesions etc. can come out. Once you've done that, you need to do a proper fenestration. You need to mobilize the root, and to do a fenestration you should try to remove as less bone as possible, especially laterally, and reach the lateral border of the root from shoulder to exit, and clear it from proximal to distal. And having exposed the nerve root, you should gently retract the nerve root over the disc. So again, see, this is the dura which I'm using to clear, and that's the epidural fat. So I'm clearing the ligamentum flavum from any adhesions, and then I use a 45-degree upcut. I use only one instrument, that's the 45-degree upcut. I do not use other ones, and I turn my arm and I use that to remove the ligamentum flavum. After this, the ligamentum flavum is removed. Some people like to use a flap, but I just like to remove it this way. It's simpler and easier. And as you can see, I've started exposing the nerve root. This is the head end, and this is the tail end. This is the medial, and this is the lateral. So I've started exposing. This is the nerve root. As you can see, it's a bit inflamed and swollen, which would be true in an indicated disc. Having done that, you then need to sort of visualize clearly the nerve root. You have to make sure there is hemostasis. And for hemostasis, you may be using a patty or whatever. So then you can see these epidurals on the disc. You mobilize the nerve root medially, and what you see below it is the disc. These epidurals you need to tackle, because if they burst later on, that they will cause a problem for you. And the worst thing in a microdiscectomy if the field keeps filling with blood. So when I'm medially retracting the root, what happens is at one point suddenly the disc pops out. So of course there is going to be a bit of bleeding, and that is the disc piece which you can see. Now the microscope helps you because you can see the beautiful rendering of the color and the texture and the disc. You know, once you do discs, you know what the disc looks like, and you can then safely grab it. What I do is that I use a suction tip as a retractor, and my left hand with the suction tip has retracted the nerve root medially to keep it safe from my other instrument. So it is a completely assistant-less surgery. The assistant does very little at this point in time, and you have to safely put in your punch. It has to be closed when you put it in and open only when you enter inside, so you don't grab the dura. And that is the sort of a discectomy. So see, that is the nerve root again, which you can retract with the dura, and then you check to see that there are no other fragments. So from proximal to distal, you look at it, and this is another case, of course. There's another case where you can see what a herniated disc looks like coming out through the rent. And I don't use a knife. I just use the same rent as far as possible to remove the fragment so that I don't make a larger defect. Because it's been shown that larger defects are responsible for recurrences. So that's the disc which is coming out now. And you gently tease it out and try to get out as much as possible without grabbing it initially, because if it breaks into pieces, then it just means more canal entries. But this way you can, if you get the whole chunk out, it's very good. So you can see the whole chunk has come out, and then I'm using a disc forceps to remove it. So my left hand is retracting the nerve root, and this is the nerve hook. The nerve hook goes all around to see that there are no loose disc fragments left under the nerve root, above, below, and inside, even underneath the posterior longitudinal ligament. And at the end of the operation, what you want to see is really the fact that there are no fragments lying outside and that the nerve root is extremely free. So hemostasis is very important, and it really begins right with positioning, because your anesthetist cannot help you if your position is bad. The arterial pressure, venous pressure, both have to be low, and the venous pressure is a little dependent on how the patient is ventilated. So you can speak to the anesthetist about the ventilator settings. I do use bipolar, but not excess, because it can cause fibrosis. And we can use gel foams and patties to push away the epidurals while you're doing your surgery. Flow seal can also be used as a last resort, but it's very expensive. So you may think about not using it. Finally, at the end of the operation, when you take out the retractor, the tissues fall in place, and what remains is this fascia. And a tight and an excellent closure of this fascia is very, very important to restore the turgor of the muscles at the back. So we use this sort of port closure thing, and this closure becomes very, very important to have a very tight and good closure of the fascia. If there's a facial defect, this patient will continue to have pain. And of course, you can see the very small incisions. And the patient is mobilized the same day. The patient was operated at 9 and is mobilized at 7. Nowadays, we even send them home in the evening, and they walk pretty comfortably by the evening. So this is just the basic procedure. I have not gone into complications, and I have not gone into tips. That is Gordon Findlay. He's one of the pioneers of the microdiscectomy and my teacher all those years ago. And I think I'll leave the rest for questions in the so thank you again.
Greetings viewers. We are going to see a total knee replacement done for a post-traumatic varus stiff knee. We are going to use a tibial tubercle osteotomy for exposure and medial epicondyl osteotomy for deformity correction, and it is computer navigation assisted surgery. This is a 50-year-old female who had a medial condyle fracture which malunited. Now she has 15 degrees flexion deformity, and range of movement is 15 to 45 degrees. You can see the scar on the medial aspect of the knee. You can see the implants has been removed except for the washer. The joint has developed arthritis. 3D reconstruction shows there is proximal and posterior migration of the medial femoral condyle. The CT scan section also shows the malunion with increased posterior condylar angle. Under spinal epidural anesthesia, patient is painted and draped. You can see the range of movements 15 to 45 degrees. And there is some varus valgus laxity as well. We open through a midline skin incision and a medial parapatellar approach. The intra-articular adhesions are being removed. We do a medial soft tissue release of the medial capsule up to the posteromedial corner. As the range of movement did not improve beyond 60 degrees, we are planning to a tibial tubercle osteotomy. We mark the medial limb of the tibial tubercle osteotomy. It is almost like 10 centimeters long. So with the oscillating saw, we are doing the osteotomy. Once we reach the lateral cortex, we just penetrate the lateral cortex and avoid going through and through, so that we can reflect the osteotomy and maintain the lateral periosteal hinge. So we reflect the entire osteotomy fragment laterally, and we gently flex the knee. Now we start the fixation of the tibial and femoral arrays for the navigation surgery. So we are putting the tibial pin. We are using the brain lab kick navigation system. The femoral arrays are being fixed now. The registration is being done on the navigation system. Once registration is complete, we check the alignment. So the pre-op deformity is around 29 degrees of varus. The valgus stress is correct 10 degrees to 19 degrees of varus. We already done the limited soft tissue release on the medial aspect. You can see the medial tightness both in flexion and extension. We do further soft tissue release. We do a posteromedial capsular release, complete posteromedial capsule release, followed by the second stage of release, which is the release of the semimembranosus attachment from the posteromedial corner of the tibia. After this release, we go for the tibial cut. The tibial cut is navigated in the brain lab system. The plan is to do a standard tibial cut with minimal resection from the lateral plateau with a 3 degrees of slope. So once we do the cut, we check with the navigation system. Here it shows 6 mm resection from the lateral plateau with a 4 degrees slope with the varus valgus of neutral. Then we navigate the distal femur cut. Again, we are aiming for a neutral mechanical alignment because of the young age of the patient. So there is minimal bone resection from the lateral plateau, lateral condyle. Check with the navigation system. So again, it's in 0.5 degrees of varus, and resection is approximately 11.5 mm from the medial femoral condyle. There is still medial tightness both in extension and flexion. So to improve the medial gap, you need to go for an osteotomy at this stage, medial epicondylar osteotomy, so that we can slide the MCL attachment down. It is migrated proximally and posteriorly due to the malunion. So we take a thick sliver of bone from the medial condyle, which includes the MCL proximal attachment. Once we do that and do a valgus stress, the joint medially opens up. Then we can put a spacer block and check the gaps. As the joint opens up medially, now we are proceeding with the medial reduction osteotomy on the tibial side, which will improve the medial gap because it reduces the tension on the MCL. We have a rough idea of the size of the femur and tibia from the navigation system, so we can use the appropriate tibial trial to do a reduction osteotomy. Once we do the medial reduction osteotomy, we go back and check the gap again with the spacer block. So we are aiming for a neutral mechanical alignment because patient is young. Once we check, we are happy with the extension gap. We are going to the femoral sizing now. So the computer gives a approximate femoral size and the rotation based on the intraoperative landmarks we are given. where I'm checking with a conventional jig also because it's a malunited femoral condyle fracture. I'm trying to match the extension rotation to the transepicondylar axis. But due to malunion, we cannot take a single reference as a conclusive landmark. So you're combining multiple techniques, conventional jig with the navigation system here. So once you put your blocks, we use the navigation system to check the rotation. Generally in a varus knee, we use 3 degrees or 5 degrees of external rotation depending on individual patient anatomy. So here we're using a 4.5 degrees external rotation. You can see the lateral gap is open 10 millimeter, but the medial it is 5.5 millimeters. So we're completing the femoral cuts, 4-in-1 jig, anterior, posterior and chamfer cuts. We are checking the rotation with the navigation system. Once you are happy with that, we are doing a notch cut for the posterior stabilized prosthesis. So I believe that posterior cruciate ligament becomes part of the deformity in gross varus deformity, and unless you release the PCL, you cannot correct the deformity. So here we are using a PS prosthesis, posterior stabilized prosthesis. We're using the trial, the 8 mm insert. As there is still lateral laxity, we're going for the next size trial, 10 mm. Checking the, as there is medial bone loss, the femoral component tend to goes into varus. So we're using a 4 mm distal femur augment on the medial side, so that it compensates for the bone loss. So now we are checking the alignment again. We bring the knee into extension and gently give a valgus stress so that the middle epicondylar fragment slides down. Once the gaps are equal, we note where the fragment is sitting so that we can refix in the same position. Similarly in flexion, we check the gaps and see where the fragment is sitting. So this is a position where we want to fix the middle epicondylar fragment. So this is the middle epicondylar osteotomy fragment. It's quite a big chunk of bone. We release the capsular attachment to the bone. We preserve the MCL attachment. The distance between the MCL attachment to the resected bone is the distance which we can slide down so that we can refix to the femoral condyle. If we slide down too much, we cannot refix. So this is the posterior part of the osteotomy which we are removing so that we can slide the fragment posteriorly, and this is the distal part of the osteotomy fragment which we are going to slide distally. So this is distal to the MCL attachment. We are removing this close to 10 millimeters of bone. So we can slide the fragment up to 10 millimeter distally. We try to displace the fragment distally. If there is any periosteal attachment which is preventing distal displacement, we can release it further. We are removing the sclerosed bone from the medial femoral condyle, distal femoral condyle. Here there was no bone resection because of the malunion. We have to remove a good amount of bone to expose the cancellous bone. It's always better to cement on a cancellous bone. So we have to change to a 8 mm augment here from a 4 mm. Now we are going to reattach the middle epicondylar fragment. We are trying to reposition it. The fragment is displaced distally and posteriorly. So we have to position it within the component to have a good bone-to-bone contact. We can use a hook reduction clamp to stabilize this temporarily, or we can use a temporary screw to stabilize this fragment. We can see this fragment is still distal and posterior, so we are doing a further posteromedial soft tissue release. This time we are releasing the superficial MCL as well. So we have done a complete posteromedial release, superficial MCL release up to 5 cm from the joint line. Now we are going back to the gaps again to check the position of the fragment. The final position looks satisfactory. The alignment is corrected and gaps are equalized. We can see the alignment is in 1.5 degree varus now from what we started at 19 degrees. The gaps are equalized, 1 to 1.5 millimeters difference between the medial and lateral side, which is perfectly acceptable. So we are going for final implant fixation. As we have used the 8 mm augment on the distal medial aspect of the femur, I am using a femoral stem extension here because the medial femoral condyle bone also is a malunion site. I wanted a better fixation, so I added a 8 mm augment on the distal femur and a femoral stem as well. I have removed the femoral and tibial arrays before I could put the femoral stem. Because I didn't anticipate the requirement of stem, I have put the femoral arrays close to the condyle. So with the arrays it's not possible to put a stem. So I removed the arrays. We are fixing the medial epicondylar fragment with a screw. You can see the fragment is within the confines of the component with a good bone-to-bone contact. Once we fix the fragment, we are going back to the alignment again. So I am using this rods to check the alignment. Because of the stem, I have removed the femoral and tibial arrays from the brain lab system. So I have to use some other technique. So this is a conventional technique of checking the alignment with the image intensifier and a rod. So the imaging of the hip, knee and ankle, and it should be in a straight line. So if you are using a navigation system, you should place your arrays such that they are within the condyle and does not interfere with the stem placement. So this hip knee ankle angle is in neutral. So the final implant, femoral component with 8 mm distal femur augment and a stem. I am using antibiotic loaded cement here, Palacos medium viscosity antibiotic cement because of the previous history of trauma. For post-traumatic arthritis, I use antibiotic cement. I use cement both on the implant surface and the bone surface. So the stem is uncemented fixation, press fit. There is cement only on the metaphyseal area. We put the trial. When the cement is set, we put the final insert. We are fixing back the tibial tubercle fragment, but we have slided it a little bit proximally. This corrects the patella baja situation. I use 2 cortical screws, bicortical fixation, which is quite stable, and we allow range of movement immediately post-op. So now I am fixing the medial epicondylar osteotomy with a small plate, 1/3 tubular plate. Because we slided the condyle distally, there was a gap between the host bone and the fragment proximally. So I used some cancellous bone and fixed the fragment with additional 2 screws with a plate. Sometimes the osteotomy fragment can break if you are trying to put multiple screws. So with the plate it is quite secure. It's rarely required, but because of the severity of deformity and gross correction required, I have to add this plate as well. So the final X-ray, you can see the alignment restored, the medial epicondyal fragment is securely fixed, the hip knee angle is restored. There's a 1 month follow-up. Patient has now 90 degrees range of movement. So the medial epicondyal osteotomy is severe varus with extra-articular femoral deformity. The tubercle osteotomy is useful if you have a stiff knee with a patella baja situation or when you want to remove a well-fixed stem.
Dear friends, today I am going to discuss the technique of percutaneous screw fixation for lateral condyle fracture in children. This 4-year-old male fell on an outstretched hand while playing Yakko. This was his injury film, which shows slightly displaced, that is conventionally described type 2 fracture of lateral condyle with olecranon and displaced fracture. The child was put on a plaster and in 1 week later there was increase in the gap, and along with olecranon fracture we decided to investigate further. In internal oblique view we could easily see that this was a type 3 Song's fracture. I would describe what Song classification is. According to Song classification, if there is a gap which is same as laterally as well as medially and less than 2 mm, it is called as a type 3 fracture. And according to Dr. Song, one needs to close, reduce and fix it either by percutaneous pinning or screw. Here, because of the additional olecranon fracture, I use percutaneous screw fixation. The fracture can be compressed by flexion and pronation of the elbow, and percutaneous pins can be passed in this position. To pass the KY, first we need to put it freely over the skin and see which is the best entry point. And once we confirm the best entry point, the KY, here I am using 2.5 mm KY, is passed percutaneously and kept at the site of the entry. Once the KY is seen perfectly at the entry point, one need to mount a drill on that. One should confirm in multiple views and then mount the drill so that we can immediately start drilling the fracture. Drive the K-wire and monitor the progress of K-wire in all the views after passing and make necessary adjustments. Assessments and adjustments are always necessary while passing the K-wire so that we do not make multiple tracks. Once the final position is satisfied, remove the drill. The KY progression can be seen here in multiple IITV images. Please confirm in lateral as well as internal oblique view. Once everything is confirmed, take a small incision for the screw insertion. The incision then can be dissected down to the bone with the help of hemostat. Once that is done, pass the sleeve over this 2.5 mm K-wire and then remove the K-wire. From the same track, replace the K-wire with a guide pin. Once the guide pin is in place, confirm whether the guide pin has gone in the same track or not. These are the X-ray view showing perfect guide pin placement. After confirmation, take the measurement for the screw and then simply pass a 4 mm cannulated cancellous screw over the guide pin because we have already drilled the track with 2.5 mm K-wire. Hence, no separate drilling is required for passage of the 4 mm cannulated cancellous screw. The final tightening preferably should be done in a flexion pronation view, which is more important for cross K-wire or a divergent K-wire rather than for a percutaneous screw, which would compress the fracture site as shown by this maneuver. This is the progression of the screw in various views. Final tightening and compression is done, and then the guide pin is removed and closure is done. The gap, you can see the gap closure here by the compression of the screw. We always do arthrography to confirm the articular congruity, which is seen beautifully here. The child is then placed in plaster for 3 weeks because we want to mobilize the child early. At 3 weeks, plaster is removed, and 1 month X-ray shows excellent union, which is best appreciated by internal oblique. The screw can be removed at 6 months easily as an OPD procedure. We thank you for watching this video. For more videos such, you can subscribe my channel. Thank you very much once again. Friends, today I am going to share a different approach, which is a postural approach for the fixation of the lateral condyle humerus fracture in children. 4-year male-old child fell from an height before 1 month. He was primarily treated by a native doctor, we call them bone setter. He presented to us with swelling, pain and restriction of movement. Let me state that the same approach may be used for fresh fracture and non-union. This child presented with a lateral prominence and movement restrictions. His AP lateral and internal oblique presentation X-ray showed type 5, strong type 5 fracture or type 3 Jacobs fracture with a flipped and rotated fragment. You start the surgery in lateral position, palpate the lateral bump, then take a posterior incision which is slightly curved on the lateral side till the apex of the lateral condylar fragment and come back to the oblique. After the incision and hemostasis, the first thing we need to do is to raise the flap. The first flap we raise is on the lateral side to reach the outermost aspect of the lateral condylar fragment. Once the flaps are raised, the second thing we do is to erase the lateral border of triceps from the humerus as well as lift it from the elbow joint capsule. This will take a few minutes. A knee dissection will help in hemostasis as well as delineation of the fractured fragments in a better way. Here I am incising the part of the triceps on elbow joint. Subperiosteal dissection of the metaphyseal part is then done, and exposure is aided by placing a bone spike over the proximal fragment. Having done that, the second thing is you delineated the fracture fragment by palpating. In non-union and late presenting case, there may be some fibrosis in between, and we start by incising the fibrosis between the metaphyseal side of the fragment and the fracture fragment. Once the metaphyseal side is inside, the second thing is you open the joint capsule over the fracture fragment. Do not touch any attachment to the lateral condylar fragment. Fibrosis between the articular surface and the lateral condylar fragment should be incised with caution. Once that is done, a blunt dissection between the metaphyseal side of the fracture and the rotated fragment is separated by hemostasis with a hemostat and a cautery forceps. To have a better alignment, it is a good idea to separate the metaphyseal fragment on anterior as well as posterior side. The fragment which is rotated and flipped outside, the rotation of the fragment is then corrected. If it is not possible to correct it manually in a delayed presenting case, some soft tissue dissection between the lateral condyle and subcutaneous plane may be required. If there is any intra-articular fibrosis at this stage, should be removed. And to confirm the articular alignment, further dissection to expose the medial joint line is carried out. Once the fragment is rotated, to manipulate the fragment in a better way, we use a joystick. Here, I am trying to coax the fragment without the use of joystick, which is a quite difficult thing to do when the patient presents late or in a case where there is a frank non-movement. Inserting the joystick helps you in aligning the fragment and remaining away from the fragment with easy manipulation. Make it sure that the joysticks comes just above the articular cartilage so that the same joystick can be advanced to fix as a horizontal key wire, which I will show you a little later. If the proximal fragment control is required, a wound clamp or a key wire could be used and should be used as a joystick. Having took control of both the segments, intra-articular part of the fracture should be aligned with the joystick, help of the joystick. Here it is advisable to spend maximum time to get good intra-articular alignment. An intra-articular alignment check may require some hard retraction of the olecranon which is present on the posterior side. Once a reasonably good articular alignment is achieved and is visualized by placing a dura forceps, first fixation is done by a K-wire which starts from the epiphyseal part of the fragment. Once the biparticle fixation is achieved, the drill is removed and IITV check is done. Here you can see one K-wire which is fixing the fracture fragment and a second joystick K-wire. At this stage, the joystick K-wire should be advanced into medial condylar fragment to give an extra fixation. The length of the wire can be checked by palpating, and after this the second K wire is passed from the metaphyseal fragment of the lateral condylar fragment. The same wire is just to create a track for the 4 mm cannulated cancellous screw which we are going to use for fixation. Once the K wire is in place, after a biparticle purchase, an IITV check is done to know the correct position of the wire. Here you can see that second K wire is fixing the metaphyseal part of the fragment over which we are going to pass the screw. After confirming the position of the K wire, measurement of the screw size is taken with help of cylinder sized K wire. After this, the K wire is removed and the same K wire is replaced by guide pin of 4 mm cannulated cancellous screw. After passing the guide pin, it is good idea to confirm that it is in the track which we have desired. After IITV confirmation, 4 mm cannulated cancellous screw is driven over the guide pin without drilling, because generally the fragments are osteoporotic in such situation and does not require any drilling. The final compression is then achieved by final few rotations of the screw. After this, a final check is done, and for the further confirmation, an arthrogram is done. I always do arthrography when there is an intra-articular operation of the elbow joint. After the arthrogram, spread the die by moving the joint in a range of movement. Here you can see the articular surface is very well aligned, and you can see the die has trickled over the lateral condylar fragment, which is now very well delineated as shown by this dotted green line. Having confirmed good articular alignment, we proceed towards closure by bending and cutting the extra K-wire. All the K-wires in this surgery are buried. Not a single K-wire is kept out because here we wish to keep the implant for a longer period of time. The same would be true in surgery for the non-union or lateral condylar fractures. At this stage, you may remove the tourniquet, achieve hemostasis, and then do a layered closure. The wires are then cut, bent, and first the triceps is closed over the proximal part, covering all the implants, and then the elbow joint capsule is also covered. It is a good idea at this stage that all the implants are very well covered by the soft tissue so that there is no prominence which hinders you in a post-operative period. After closure of the joint capsule, the last thing you close is subcutaneous layer. After subcutaneous layer closure, the final closure is then done by subcuticular stitches. The child is post-operatively immobilized in above the knee, above the elbow cluster for 6 weeks. Let's look at a representative case. 5-year-old female presented to us with 1-year-old injury. She was also treated by native doctors and she had concerns of movement restriction, inability to lift weight, activity-related pain. This is how she presented to us with minor deformity and mild restriction of terminal restriction of flexion on the right side. Her X-ray showed again type 5 sound injury with frank non-union. You can have a look at the comparative view of the left side. She presented to us with CT scan, which in my opinion has a very limited value in preoperative planning of this fracture.
This is a small procedure of mini incident fixation of PCL. If you see the approaches, it was started like this on the left side first. Then if we go right side.
Jignesh bhai, if you stop your video, self video, probably the audio will be clear.
Yeah.
Yes, yes.
Can you stop?
Yes, I will stop. Don't worry.
Yeah. So go ahead now.
Yeah. So these all 3 incisions you can see how we can reduce the morbidity of incision and dissection. Almost we are doing the same dissection, but we are doing in a very delicate way and just directly reach to the fragment and fix the fragment under the vision. So this is the case. This is type 3 avulsion of the PCL. It is totally avulsed from the crater base, and this is the CT scan showing the fragment size, and that's the approach. So first is a showing that yellow line is a skin incision and blue dotted line is a split inside the gastrocnemius muscle medial head. So we split in 2 parts, and the medial half will protect the vessels. So that's the incision, about 1 inches.
Optimize.
Across the optimize career side.
Okay.
Yeah, it is showing nicely.
Across the crease, oblique incision, small cut skin and subcutaneous tissue, and we will reach to the fascia. Now it is retracted the fascia. Now we can see the muscle covering the fascia. Two retractors are placed after cutting skin and subcutaneous tissue, and now there is a way. So now my knife direction has changed, and I am going along the line of fibers of the gastrocnemius, medial head, and I will release the just fascia and not the muscle. No muscle cut. So it is done. And in the next picture, you can see there is a split between two fibers. So you can just split the fiber between with finger only. Just run your index finger, and you will be able to reach there. And once both the fragments are, both the heads to the gastrocnemius are retracted, we can see the popliteal fascia. This is the popliteal fascia. Both heads split and retracted, and my artery is palpating the fragment. That is the fragment. And in circle in center, you can see the picture. And now I will cut directly on the fragment of fascia, popliteal fascia, with the knife. No blunt dissection here, because everything will be easily identified and can be detected nicely. And so fascia is cut, and we can see that this is the fragment. Once the fascia is cut, use the suction, so the blood will be sucked, and you can elevate the fragment in front of your eyes with the artery forceps. See, I can elevate and reduce. And this is the fragment picture.
Yes.
Now fragment is provisionally fixed with the 1 kVAR eccentrically. So I am leaving the central part of the fragment for the screw placement. And so I just drill the proximal part of the fragment, and just push directly fully threaded screw, non-cannulated, about 50 millimeter with the washer. If the fragment is in 2-3 fragments, then I use the spike washer. And that's the closer. And that screw. I image. Another case, similar case, it will take about 1 minute. Same, you can see the same fragment is there. And type 3 again. And we will just revise a video again. Sorry. I am cutting the skin and little bit larger incision for a demo than the previous one. Same skin circuit cut. And I have marked a round circle where I am going to get a PCL fragment. And at the horizontal line is a crease. Cutting skin and subcutaneous tissue. Fascia is cut. Now I am separating the fragment muscle fibers with my finger, and you can see inside there is a popliteal fascia deeply, and you can palpate the fragment which is elevated underneath the fascia. Now I am cutting the fascia over the fragment. My spike will be over the border of the tibia. This is the spike, where I put the spike. The picture showing where the spike will be distal to greater. My spike is here, that is in the distal to greater, and I can see the fragment. You can elevate the fragment, see. You can see the fragment clearly with the artery forceps, which is elevated. Now I can reduce it. Put provisional wire on the side and put a screw.
And that provisional wire also gives you the direction of the screw drilling.
Yeah, you can usually orient it, so there won't be any problem. You remain at the top of the fragment to drill. The screw is fixed, and you can see the IRTB images. This is the closer. This is a little bit larger incision just to have a better idea. Another one, just case, similar fragment and similar incision is there. The screw. Another one, just 30 seconds. Another piece, PCL fragment. These two small incisions are there, and you can see the fragment.
Yes.
See, you can see the fragment in front of your eyes. You can see whole crater. Put a spike distal to the crater. Reduce under vision. Provisional fix with K-wire and put a screw. Thank you, sir.
Any reason you are using a fully threaded screw? You feel that probably a partially threaded may not be, it will not be a better option here. You must be having your reasons.
Yeah. So partially threaded screw has a very less threads at the tip only.
Jignesh bhai, you can switch on your video.
Yes, I am doing. I will have to ask him to do. I am doing that.
His video was so
Yes, fantastic.
fantastic. We could ourselves palpate the fragment. It was
Yes.
Exactly. Yeah.
Sir, partially threaded screw has a very few threads at the tip only, and I am not using a bicortical screw. So to have a better purchase is a dense cancellous bone in the tibia.
I have sent you a request to start your video. You can start your video.
Yeah. So to get a better purchase in a subchondral bone of the tibia of the screw, I use fully threaded screw. As I am drilling the proximal portion, it works as almost like a lag screw, and it presses the fragment very well. And we had a number of cases, and none of the screws backed out.
Jignesh, when you have a larger fragment.
Yeah, you can use two screws.
No. Let me complete. When you have a larger fragment and where it goes towards the center of the tibia, that means anteriorly.
Yeah.
Now your trajectory of the screw is such, it is posterior.
Yeah.
Okay. So when you tighten it, it will open anteriorly.
Yeah.
So in those situations, what do you do?
Sir, if the fragment is very large and you cannot see the completely fragment, then I will open a little bit more. I will see the complete fragment, press it anteriorly when I put the screw posteriorly.
And how many times you have used a plate, additional plate to have a purchase on that?
Sir, when the fragment is very big and it is going on the posterior column, posterior cortex also.
Okay.
Then we have used a small buttress plate, 2 hole or 3 hole, like a hook, and put it like that, put it down. Okay. Because there is no base to put a screw from the top.
So anti-glide
plate.
For the information I am asking, I am not sure what it is. Whether the arthroscopists can do the same job with the screw.
Sir, they can do same things, but there are a number of articles saying that it is, you need a very, very high level of expertise, one thing. Second thing, time will be more than this procedure. This procedure takes 12 minutes, 12 to 15 minutes only.
That is to Jignesh.
Yes. very small incision. Sir, and third thing will be, arthroscopy will not give this type of the compression and reduction of the fragment.
Okay. Jignesh,
literature, sir. I have no experience.
Yeah.
And also in literature, antero-posterior screw is also described.
Yeah.
From the anterior cortex to the PCL.
Yeah.
Yes.
So how good is the fixation of that screw?
Sir, you don't need too much stable fixation. This single screw holds the things very well in most of the literature support now. And in latest 3 articles after 17, 18 and 19, they all suggest that you use a single one screw will give adequate fixation and optimum outcome in this type of injury.
So there is no much forces later on.
Yes. There are no active muscle forces acting on this.
Dr. Chandok wants to say something. Yes,
Yeah. Jignesh, when you started using PCL fixations,
yes, sir,
you must have opened by a good incision posteriorly.
Sir, first case I did after just passing my MS orthopedics in 1994, I did with a large S-shaped incision. With going between 2 heads of gastrocnemius, it took me 2 hours, and I had a lot of tension of vessel and all these problems. So gradually over a period of time, we did more number of cases. Now we have done more than 200 cases. And because of experience and more of an exposure of the posterior condyle tibia fracture, I got an idea that this can be done like this.
Okay. So your last 10, 50, 25 cases are mini open?
Yeah, sir. Almost more than 30 cases are mini open now, last 2 years.
And most of the...
सूरत में इतना सब cases होता है?
सबको PCL में
वो सब जिग्नेश के पास जाता है PBL
ये पूरा
गुजरात घूमता है, सूरत नहीं।
पूरा गुजरात घूमता है। he does that.
इंदौर आकर के करके गया एक डॉक्टर के रिलेटिव को, उस दिन मीटिंग में इधर था, शाम को उस दिन तुड़वाया, टीबीएल कोंडाई शाम को किया।
जिग्नेश भाई, I must
इसी के लिए फ्रैक्चर करवाया उसने।
We must really appreciate.
Jignesh bhai, there is a question from Dr. Mahapatra again. If the fragment is very small, what is your suspend loop or
yes. If the fragment is very small, but the fragment will not be totally free, it will be attached with the fibers of the PCL fragment, PCL. So what you do, you go through the substance of PCL and use a spike washer and press the fragment under the washer.
Yes.
There will be one more question from Dr. Sauji about a jig, available jig.
No, that is not a question here, sir. Fantastic.
Jignesh bhai, fantastic.
Yes,
Swapnil, by that time, keep your presentation ready.
I can see Dr. Dhaval wants to ask.
Yes.
Dhaval sir.
Yes,
Jignesh, the only problem with this is, suppose you have to take out pull-out stitches.
You get a just little bit longer incision distally, and you will be able to see posters of the tibia, and you can do everything.
Room for maneuvering a big Achibond needle will be very small over there in that.
Sir, you extend the incision 1 inch more distally, and you will get lot of room for doing everything. So your incision will become 2 inches or 2.5 inches. That's all.
But again, the approach will be splitting the delta, splitting the gastrocnemius. Not retracting the medial head.
No.
You are extending that same split, I think. You are extending.
By and large, you are fixed by your idea that we are going to with this method. So if you are going to do pull-out scissor and all these methods, then you may just do regular posterior incision and retract the head medially and do it.
Anytime you have to release the medial head.
No, sir. Doing this procedure, fragment fixation not. Initially, I used to do like that, larger incision. But then I got an idea that too much of the bulk of the muscle to be retracted. So split will make the retraction half, and it will take me to the fragment directly.
And how many miles you will go to do this approximately?
Yes, sir.
How many miles you go?
How many miles you would go if we call you somewhere or somewhere?
Whether you will go to Bombay to do this?
4 hours. Sir, anywhere you will call, I will come definitely.
धवल भाई, वो जो needle का आप बोलता है इट्थीबॉन्ड की, you use a fiber wire needle that is very sturdy, very small, very small, and very good. And the fiber wire is stronger than the itthybond.
Yes.
Knotting also is good.
Year-old female. She has a history of pain for 2 years. Specifically, the pain increase on stair climbing and squatting. The intensity of pain increases for the last 2 months, and that can affect her daily activity. There is a posterior medial joint line tenderness. There is no FFD, no coronal pain deformity, and the deep flexion is painful. And if you see the X-ray, and if you go back to your OPD and imagine, so this is a very common X-ray that you will see in your OPD. Every OPD you will see about 3 to 4 patients per day, which will present to you with this sort of X-ray, and you will label them as early osteoarthritis, and we will be doing all sort of procedure like physiotherapy, occasional injections, PRP, whatever. So this is a very common presentation that you have in your OPD with early, which is called as early osteoarthritis in our practice. And here you can say there is little bit decrease in the joint space on the medial side. The lateral space is relatively okay. This is relatively a difficult case because, as I told you from history, she has a chronic sort of a tear and she has symptoms for about 2 years. Okay. And when we do the MRI, you can see that there is a significant extrusion here. That there is a ghost sign which is present here. Now, the options here at this point of time are conservative. You can put injections. You can do arthroscopic debridement. You can do an arthroscopic transtibial root tear. You can do a high tibial osteotomy here, and you can do a unicondylar knee arthroplasty. So all these options are there. But what we have done is something different from everything which is described here. So this is what we did is called as a root fix technique. So this is a low profile fixation. There is no metal involved in this whole procedure. We address the pathology. The concept is to make the meniscus functional from a non-functional extruded meniscus. this is a all suture implants. The fixation is exactly at the root. The working length is very less, so there is very less bungee effect. The anchor fixes the root where it is stopped. Now this is a surgical video. So if you see, you can appreciate, as I was discussing, that there is an anteromedial arthritis here. So technically, if you go on with the uni guys, so they will say that this is relative indications, extended indications uni you can do in this particular case. So there is a anteromedial region of loss of cartilage on the tibia. So here, because this is a chronic case, we are doing a procedure which is more extensive than a root fix anchor alone. So here we are doing a X fix anchor. This is called as an extrusion repair anchor, and this anchor is inserted from a high anteromedial portal here. And this is my first anchor. This is an anti-grade anchor, just like our other anchors. But this anchor has the quality. We have reduced the thread size, so that the knots that we make here are very, very low profile, and that they are not irritant to the cartilage. Okay, so this is how this anchor is different from the conventional all suture anchors which is available in the market. So here you can see that we are passing. Now the next sort of procedure is similar to your Bankart repair. So we are using the suture sequentially here. We are passing it through the lasso, and sequentially we will be doing one by one passages. So again, this is a double loaded suture. So we have 4 limbs. All the 4 limbs are passed sequentially almost at the level of the menisco-capsular junction. Okay, so all the 4 threads are now passed like this. This is the first anchor. This is a first anchor which we have put for the meniscus. As I told you, this is a relatively extended indication for us as well. So we didn't want to take a chance. So we are putting more anchors. So this is the second anchor that we put, and this second anchor is relatively anterior to the first anchor. And with that also we are putting anchors. We are passing all the 4 sutures sequentially. So once we have passed all the 8 sutures from these 2 anchors, we will be tying these anchors back onto the meniscus. So by doing this, you will see that this chondral defect which was there is relatively covered. So this meniscus will actually give some protection to this sort of a chondral lesion, specifically if the patient is walking or bearing weight. So what we want to do is we want to bring the meniscus inside. We want it. This is basically an anti-extrusion stitches that we are placing. So one by one we are placing it. This is the first, this is the second, third and fourth. So 4 stitches in all to reduce the extrusion. Once we are done with that, now we are focusing our attention to the root. Here you can see that this root is badly torn. The condition of the meniscus is also posteriorly it is not good. And now we are putting a root repair jig here, and we are passing the wire. Now this system has an inbuilt, the root fix anchor system has an inbuilt set. So what it will do is you put a bead pin there. After that there is a long spinal needle. You can put in the same hole, and over that hole you can railroad the metal nitinol wire, which can be railroaded over the loop-in suture. So this is everything is available inside the set itself, and then you pull the loop-in set. The only thing you need to take care here is after loop-in you load the root fix anchor like this. This is the point where you have to stop, and then you have to apply artery on the anterior part, because this is a unidirectional anchor. If you pull it very hard, the anchor will come out of the tibia. So you have to put an artery anteriorly so that it will go only 2 centimeters, 1 to 2 centimeters deep, and not more than that. So this is an important step, putting an artery on the anterior part of the portal. So once it is deployed, you can see that these are 4 anchors, and you can sequentially pass sutures through the meniscus here. So you have to pass anchors sequentially here, one anchors here, and by that actually here this repair that we are doing is called as a Mason-Allen repair. So Mason-Allen repair means you put 3 knots, 3 passages of the sutures, and one is a simple suture. So this is a simple suture. So we close it, the meniscus will repair its, come at its own position, it will reduce at its own position, and then we'll repair the side to side. So it is like this. It's a cross kind of a repair. This is called as Masonry repair. So one repair like this and one repair like this. So this is the final construct, and we'll cut the threads after that. So very nicely done. We have put 3 sutures. Everything has been done in a very nice place. But as I told you, this was a relatively extended indication. We went further because there was some extrusion on the posterior medial side as well. So again, we put one anchor, root fix anchor on the posterior medial aspect as well, and we put a anchor there. So this is again the root fix anchor we have passed. So if you see the surface of the tibia, the posterior 40% you can address with a root fix anchor, and the anterior 60% you can address by using a extrusion repair anchor. Okay, so by this again we use the same anchor. The anchor goes, the anchor locks into the cavity. The threads are remaining outside, and then we can just pass the suture slowly there, and after that we will just close it up. Okay, so all the 4 sutures are passed. In a way, what we want is we want to pull the meniscus back into its own position, prevent the extrusion, so that we hope that this meniscus functions a little bit. And our goal here is to actually increase the longevity of this knee. We have a good number of these patients we have operated, and realistically we see the patient will come into the follow-up in about 6 months, 1 year, and they'll say that they are around 60 to 70% better as far as the pain part is concerned, and typically the walking has become much more comfortable as compared to the pre-op status. So this is the final picture. We have put 1, 2, 3 and 4 anchors, a circumferential repair to reduce the extrusion and to repair the root, and after that we are doing a little bit of microfracture here to increase the blood circulation in this particular area of the because this area again is actually in the direct contact of the bone to bone, but here when we have done extrusion repair, a little bit of loading on this particular portion will be reduced. Now the other important thing is the bad pattern of root tears can be addressed. So if you have a root tear like a radial tear, you can do a side to side repair also. So you put one anchor here, and you put one anchor here, one suture here and one suture here, and do a side to side closure like this, which is not possible in the transtibial technique. So a bad type of tear, type 2, types 2C, 2B, where you have some sort of a remnant which is remaining, you can pass sutures into that remnant and repair that as well. So this is the pre-op picture of this patient. This is the post-op picture. You can see that very significant extrusion was there. Very significant extrusion in the root tear. A lot of large truncation sign was there here, and this is much better here. And you can see the anchor here. You can see this area. This is the area of the anchor. The anchor is there, and the root is much better sitting as compared to here. Here there is a large gap. Here there is a very small gap, and this is also a hyper intensity. This may be because of the hip, so it is reduced a lot. You can see the extrusion is also very much improved. The other thing, you can see hyper intensity here on the medial aspect here. That is due to overloading, medial overloading. Here in follow-ups, the meniscus is much better inside, and there is no hyper intensity here. This is around 4 months follow-up. So the patient does not have a hyper intensity here, so there is not much of medial overloading. So again, this is pre-op and post-op. This is the ghost sign, and the ghost sign is relatively better now. This is the ghost sign, and this is the meniscus. So meniscus was not well seen here. Here you can see the meniscus nicely. This is the anchor you can see on the MRI images. This black one is actually the anchor, which you can see. And this axial scan, you can actually see all the 4 anchors.
Hello everyone. Today I am going to present a case of an irreparable massive rotator cuff tear treated with superior capsule reconstruction. I, Dr. Vaibhav Kohli, along with Dr. Aditya Gunchatikar, have performed this case. We had a 46-year-old male, right hand dominant, complained of pain at right shoulder since more than 8 months, which aggravated after a fall 15 days back. Patient was not able to lift his right upper limb after recent fall and had pseudoparalysis. On examination, his forward elevation was about 0 to 30 degrees. The power of his supraspinatus was 2 by 5, infraspinatus 3 by 5, and subscapularis 4 by 5. His X-ray showed proximal migration of the humeral head, decreased acromio-humeral distance, and there was no glenohumeral arthritis. His MRI showed grade 3 massive rotator cuff tear and a grade 3 gutilier. On entering his right shoulder, viewing from the subacromial space, we can see the humeral head, the glenoid, and massive rotator cuff tear. We have performed the biceps tenotomy for this patient. The patient is in a lateral decubitus position. We start by removing the subacromial bursa using a radiofrequency ablation device. It is important to clear this bursa so as to have a good visualization. We use a shaver to complete this step. Now we are taking a posterolateral portal viewing from the anterolateral portal. We are trying to grasp the cuff and get it back to its native insertion, but the tissue is friable and tears easily. Even after making adequate releases, superior and inferior to the cuff, we are not able to get the rotator cuff tissue back to its footprint, and the tissue, as you can see, is in a lot of tension. So we decided to go ahead with superior capsule reconstruction. We start with the preparation of the superior surface of the glenoid. We are using a RF to clear out the soft tissue. We want a nice bleeding bony surface. To achieve this, we are using a burr. Here we can see the superior surface of the glenoid. All the soft tissue has been removed and we have achieved a good bleeding bony surface. The same is performed on the humeral side over the greater tuberosity. It is important to get a good bleeding bony surface over the glenoid and the greater tuberosity so as to achieve good healing of the graft. After this is complete, we start with the insertion of our glenoid anchors. We have made an incision with the knife through which glenoid anchors will come in. We are going to insert two anchors in the glenoid, one on the anterosuperior surface of the glenoid at around 2 o'clock to 1 o'clock position, and the second on the posterior superior surface of the glenoid at around 10 o'clock to 11 o'clock position. You can see the sleeve coming in. Once the sleeve is placed at its desired position, we drill a hole and insert our first anchor. We now retrieve these sutures from the first anchor into another portal so that they do not come in the way while inserting our second glenoid anchor. Now you can see the sleeve coming in for the second anchor. We need to place the anchors far medially over the glenoid so as to have a good bony surface over the glenoid for the graft to heal. We are using 3 mm double loaded peak anchors for the glenoid. Each anchor has one tiger and one blue fiber wire. To avoid suture entanglement and for proper suture management, we park the sutures from the posterior anchor in the posterior portal and the sutures from the anterior anchor into the anterosuperior portal. We now move on the humeral side for the insertion of medial row anchors. We insert one anchor on the anterior part of the footprint and the second anchor on the posterior part of the footprint. We are using 5 mm double loaded titanium anchors for this. Once this is done, we proceed with the measurements. First, we measure the distance between the glenoid and the medial row humeral head anchors. The next measurement we take is between the two medial row humeral head anchors. Then we measure the distance between the two glenoid anchors. And the last measurement is between the medial row humeral head anchor and the to be inserted lateral row anchor. Once the measurements are complete, we proceed to harvest the tensor fascia lata graft. The anatomical references for this are proximally 15 cm distal to the ASS, distally 10 cm proximal to the lateral femoral condyle and 4 cm anterior to the intermuscular septum. We prepare the graft by folding it over to a size matching the arthroscopic measurements and suturing its periphery with continuous stitch. Ideally, the thickness of the graft should be between 5 to 8 mm. We now insert a passport cannula into a lateral portal and retrieve all the sutures out from the passport cannula. We pass all the sutures from the glenoid and the humeral head anchors through the predetermined points in the graft, and by using a parachute technique, we pass the graft inside the joint. To do this, we will be using one tiger wire of each glenoid anchor and tie them to each other. They will act as shuttling sutures. By pulling the remaining two free ends of the tiger wire, we will be passing the graft inside. Meticulous suture management is maintained throughout. No intertwining of the sutures should be there to avoid entanglement of the graft. So here you can see the graft coming in. We keep pulling on the two free ends of the tiger wire of the glenoid anchor till the graft is well seated over the superior surface of the glenoid. Once we are satisfied, we will tie these two free ends of the tiger wire to each other using a standard knot. After this, we tie the remaining two blue fiber wires of the glenoid anchors using the standard knot technique. This secures the medial edge of the graft. Now the attention is turned to securing the lateral edge of the graft to the humeral head. We do this by tying mattress sutures on the medial row anchors of the humeral head. All these sutures from the medial row humeral head anchors are passed through the knotless peak anchor which we are using for the lateral row. After the insertion of the lateral row anchor, we can see that we have achieved good compression of the graft over the greater tuberosity. We are now moving the humeral head and you can see the graft moving along with it. This confirms that the graft is well secured to the humeral head. As you can see, we have achieved a nice coverage of the greater tuberosity and the graft move along with the movement of the humeral head. Then we go intra-articular to see the graft from within the joint. This is the glenoid. This is the humeral head. You can see the graft covering the humeral head and going right up to the greater tuberosity. It nicely covers the humeral head. Now slowly, as we are going towards the glenoid, you can see the graft extending right till the superior surface of the glenoid and is well secured. So this completes our superior capsule reconstruction. Post-op X-ray shows an increase in acromiohumeral distance. So we can see the post-op outcome at the end of 7 months. Patient has a forward elevation to about 90 degrees, an internal rotation till about L2, and an external rotation of about 20 to 30 degrees. More importantly, the patient is pain-free. Thank you.
Good morning and thank you for joining us on this recording of spinal scoliosis correction using the old technique of using a spinal loop rectangle as well as sublaminar wires. This is a technique that's been forgotten by many, but it's a technique that still holds good in our book, and we aggressively promote this because it can save a lot of top dollar, especially while doing these surgeries in rural settings. Now, this is a child with a King type 4 curve, and it's a stiff right-sided convex curve. You see a scar on her left chest. That is a patent ductus arteriosus surgery done in childhood, and hence this becomes a syndromic scoliosis. The argument here would be for a stiff curve with a relatively flexible lumbar spine to stop at L3, but with using sublaminar wires which derotate the spine but don't do as much justice to derotation as maybe screws and rods. You would want to go to L4 here and not stop or not use L3 as your LIV. Whether this has a long-term repercussion or not remains circumspect. Here's the planning, and it's some sublaminar wires actually are a polysegmental implant, which means that you would use wires at every level, and that makes the construct really rigid and makes the power of correction also extremely well distributed and strong. You see the incision is straight, and we go right down onto the bone. You do, you get on the top of the spinous processes, and at this point, I'm going to say that the time you spend on the exposure, which should be clean, bloodless, and cadaveric, if you may, which means that you got to get it right down to bare bone. That time will help you save a lot of other sweat during the actual operation. So do spend extra time in exposure. We like to use a lot of cautery, and we get the bare bone down exposed. The lateral extent of the exposure should be to the tip of the transverse processes. Especially in the lumbar spine, you got to dig them out. In the thoracic spine or the convex side, they seem to present themselves because the transverse processes really stick out, and you end up landing up on the rib. But on the concavity, sometimes you got to really again go down and look for them because they're a bit deep, and you can risk getting into the pleural cavity if you are not careful. So on the concave side, be a bit careful. Once the exposure is done, interspinous separation is done. So remove the interspinous ligament meticulously and scrupulously, and this includes the use of blunt nibbler, and along with that you're peeling off the supraspinous ligament but making sure that every part of the bone is intact, which means you use your nibbler with very soft hands and don't bite bone. Now after this is done, you layer down the yellow ligament, which means the yellow ligament is like a stack of ligaments kept one on top of the other. With the nibbler, if you thin it down and shallow it down, you can then start using your ronger, the 3 and 2 number ronger, to start clearing the interlaminar ligament, which is the interlaminar ligament, which is the yellow ligament. The yellow ligament always presents itself with a cleft in the center, and that cleft is often displaced. You can see it on the video now. that cleft is sometimes displaced to the side in scoliosis. You use your ronger as to slot in this in the space in this yellow ligament and start working centrifugally from the center to the outside. And again, using soft hands, making sure that you go as laterally as you can, but avoid biting the inferior or the superior surface of the lamina on either side. Because if you take that bone down, it takes away the hold of the sublaminar wire, which will now start cutting into the lamina. So the cortex of the lamina is really where the sublaminar wire holds, and you want to be very, very careful to not bite that. So you notice the surgeon is using a very soft grip and not biting hard. So wherever he finds resistance to his punch, he will give way and go and focus on the ligament. As you remove this ligament and go distally, you will find that there is a lot of give in the bone. This is the 20 gauge cold cured doubled sublaminar wire. It is ready-made, and the loops are such that there are 4 loops in this wire. You see, the technique of passing the wire is very simple. It's like taking a needle and taking a large suture, because when you pass the needle and you curve your wrist along the circumference of the needle does not bend. Similarly, you see the surgeon is toggling the wire in such a way that as it exits, it retains its shape. Now, at the tip of the wire, there's one bend, which is a sharp 90-degree bend, which is the sound or the probe of the wire, which helps you scrape the wire from underneath the lamina. So that's really scraping on the undersurface of the lamina, ensuring that the wire is not going haywire. And once the wire is through, you can feel the pop of that tip coming across from the space on the other side. The next bend is a soft bend, which helps the wire bounce off the thecal sac. The next bend is the bend that's number 3, which is where the wire is bent at a 90 degrees to conform to the length of the lamina, which is different at different levels in the same patient. So you've got to keep changing that. And the 4th bend, of course, is the one that conforms with the surgeon's wrists to ensure smooth wire passage. Now, all these wires have been passed. At this point, you got to declutter and ensure that you start pairing the correct wires, which means that when there's like 48 ends staring at you, you want to make sure that the 2 wires that are going to marry each other, so to say, belong to the same wire, the 2 ends. The bending technique, because this is a 6 millimeters, stainless steel rod, doubled and soldered. You can't bend this with the standard benders, and you need this French press to actually bend the wire. We give it the bend of a Cindy Crawford back, as we say, the most ideal shape of in the sagittal profile. And now you start putting in the bent end on the inside, keeping the soldered end on the outside. Follow one pattern so there's no confusion, and also start marrying the correct tips. By moving the wire, you'll know which tip belongs to which end, and make the first twist so as to keep the 2 married wires together forever. You will see as you start doing your first twists, a significant part of the apex of the scoliosis remains outside your rectangle, as you see over here at the left end of the picture. But as you start doing the correction, you'll see this coming in, and that suggests that the correction is quite robust. The way to tighten the wires is that you start with 2 wires on either or 2 pairs on either end of the heart shell rectangle to ensure that the heart shell is locked in place. So we've tightened the convex and the concave side at the top and at the bottom with 2 wires each. And now the surgeon is tightening the concavity, the wires on the concavity serially from distal to proximal, which means in a centrifugal manner. Again, 2 on the top, 2 at the bottom, 2 on the top, 2 at the bottom. So gradually getting the apex in the center. And as that is done, remember the way this is tightened, it is tightened in the lateral manner so as to pull the spine, translate the spine towards the rod. And currently you're still seeing the locking of the spinal loop rectangle. But this is the corrective maneuver, and you'll see that as the wire is being tightened, the spinous processes start getting pulled towards the midline to a point where all the spinous processes will then get within the confines of the spinal loop rectangle. And that is a pretty hardy correction. So once you do this sequentially, from distal to proximal, which is from both ends coming towards the center, the force is distributed quite nicely. Primary tightening is when you get the entire twist of the tightening down to the rod, and that is your first tightening. Ensure that the soft tissue keeps going away. You'll see the spinous processes are coming in the midline, and once this kind of primary tightening is done, you then go to the convex side and then tighten vertically downwards to cause some kind of a cantilever maneuver of the convex rod on the on the rib hump or on the apex. After this, trim the wires to suit your comfort, and then start doing what is called secondary tightening, where the looped up wire starts to loop upon itself, which is the final end of your tightening. Beyond this, the wire could crack. Incidentally, if the wire does crack, you still have the capacity to pass a new wire through the midline, and all is not lost, unlike when you use pedicle screws. So this is the process of secondary tightening or final tightening, where you're actually twisting the wire until it twists on itself. All the time, neurological monitoring or neurophysiology is being monitored through this process. And you can see all the spinous processes are now stacked up beautifully in the midline, after which you would put gel foam pieces to block the interspinous spaces that have been created, because then you're going to be putting bone graft on top. You could use bone, of course, you want to use the chiseling technique or Mohs technique to decorticate or petling of the spinous processes, leaving the midline of the spinous processes intact to retain the post-operative furrow or in the spine, which is very cosmetically important. And then you put the bone graft. Here we have used some artificial bone, but you can use any form of bone graft that you prefer. And closure is then done in 3 layers over a drain, and you could use subcuticular stitches or clips. At the end, the correction, like I said, is pretty robust, and you can end up with a pretty good straight spine in the coronal plane as well as the sagittal plane, still leaving a couple of discs below for for further use. And with this kind of a correction, you can get a good cosmetic result, and you can dare say that this implant actually is a close competition to the modern implants in most of the cases, except when you're planning selective thoracic fusion, which is few and far in between. So do learn this technique, because it's going to bail you out in a lot of situations. And that's my game. If you have any questions, please reach out. Thank you, Wiroc, and thank you, Bombay Orthopaedic Society, for giving us this opportunity.
Hello, I am Vishal Peshattiwar. This talk is on percutaneous pedicle screw fixation. Well, to start, you need to have a good C-arm, a better C-arm technician, a good radiolucent table, and radiation protection equipment. There's no point in passing pedicle screws with a technician who is undertrained or with a C-arm that is not going to show you good quality images. Of course, there can be no more emphasis than giving on radiation protection equipment, because you don't want to end up getting the side effects of radiation, as serious as cancer. Well, as you can see here, this is an image I borrowed from Dr. Vikas Gupte. You can pass a pedicle screw through a tube using the normal landmarks as we do in a classic open surgery, and how to pass that is very similar to an open surgery. However, if you were to pass a percutaneous screw, there are certain things that don't change. If you were to take a coronal plane cut through the spinal column, you have to be wary of these two structures while passing the screw. Those neural elements, the root and the dorsal root ganglion, are medial and inferior to the pedicle. Hence, an ideal placement of screw is somewhere in the center or the lateral aspect of the center and in the superior quadrant. Well, how do you achieve this? When you put your Jamshedi needle, that's the C-arm image of a surgery that has been done nearly 14 years ago. The entry point of the J needle is an optimal place that's between 2 o'clock and 3 o'clock position if it is on the right side of your screen. It should be in the outer and just above the center of these two cross sections. One question then asked is, why not go a little more superior? If you go superior, you have to take in account this facet joint. The maximum adjacent level violations happened in the initial surgeries when the screws were put in more superior, because the tulip went and sat on the adjacent facet joint, giving rise to adjacent level arthropathy. So it is either between 2 o'clock and 3 o'clock on the right hand side, and in between 10 and 9 o'clock on the left hand side of a pedicle, as shown here. Most of you have done vertigoplasty. Passing a percutaneous screw becomes easier if you have experience with vertigoplasty. If this is a sagittal plane of a vertebral column, that's an ideal trocar placement in a vertigoplasty. Similarly, if this is the point on the skin that you have marked, which is the lateral border of the pedicle, as you can see here, never start your entry here, because if you start at this point, the trajectory as you point it inwards will violate somewhere around the medial aspect of the pedicle and go more medially than you're comfortable with. So in such cases, it is better to go a little more lateral. About 2 to 3 centimeters lateral to the lateral aspect of the pedicle is an ideal entry point for a percutaneous pedicle screw to be passed. Once you have this, it gives you a wide and a very medialized screw, not what would happen if you were to start immediately at the lateral aspect of the pedicle. This 2 to 3 centimeters gives you an ideal placement of the screw as desired. Well, this is an CT image of a vertebra with 2 pedicle screws. This one is what you don't want, because this is very, very close to the facet joint, isn't long enough, and does not give you good purchase. Whereas the one on the right hand side of the screen is what you should be aiming at every single time you pass a screw. Another important aspect to note, to remain inside the canal of the pedicle and not violate the vertebral canal, you have to remember that while in the lateral plane, the needle has crossed the base of the pedicle and entered the vertebral body. In the AP plane, it should still be inside the pedicle. So while this is happening, what it means is when it has reached this aspect, it has already crossed beyond the pedicle. So now it's safe to tap it in more beyond this point, because you're not entering the canal, but you are in the safe confines of the pedicle wall. If you understand this one fundamental concept, passing a pedicle screw is like a child's play. Well, a guide wire is then passed inside the hollow canal of the Jamshedi needle. You have to remember that a guide wire should never go beyond halfway mark, especially in osteoporotic and frail patients, because this is the single most dangerous equipment that you will be handling while doing an investigative. Any migration of the guide wire in the abdominal cavity will have disastrous consequences. After that, you have to tap. This, like I said, is more than a decade and a half old image. We used to tap right just shy of the tip. Right now, we just go beyond the pedicle and come back. So this ensures that the guide wire does not travel back with the tap, and it gives the self-tapping screws a little more bite at the vertebral body. Well, this is a short video to show how this was done. This is again of the same case, I think more than a decade old. So you can see where my hemostat is. This is where my hemostat is. That's the lateral aspect of the pedicle, and I'm going about 2 centimeters lateral to it. You have to take a good incision. I felt the transverse process there, and that's the image where you can see that's the needle that's at the 2 and 3 o'clock position, and I pushed it in. It is already beyond the base of the pedicle here, but still in the middle aspect. Once that is confirmed, this wire has been passed. The wire is somewhere at halfway mark. We are now going to dilate serially over this so that the tap that goes in does not take a bite of the muscle. A serial dilator will then open up the muscles to let the tap go safely. Once the final dilator is in, and you are confirmed that it's seating on the top of the pedicle, then you should use a tap. While you're doing it, it is always wise to stabilize the wire so that this wire does not migrate forward with the tap if there are some debris collected in the tap, or if the tap is going at an angle. So somebody has to stabilize this wire. Once you have tapped, this is too long. Nowadays, you can just go beyond the base of the pedicle. Then it has to be taken out. It's again wiser for somebody to protect this guide wire from coming out, as it will save you the time of having to reinsert it again. Once this is out, then it is the time to put a right size pre-measured screw inside. While you're putting in the screw, again, somebody needs to hold on to that wire so that it does not migrate in. Understand that the tulip of a screw is about 16 millimeters in most cases. So your incision has to be about 18 to 20 millimeters to let it go inside. Otherwise, it is going to carry the adhesive drape, as you can see in this case. To avoid this, it is better to take a little more generous incision and let the screw set in at the base. This is the same procedure that you follow for the next level. Here I'm just tilting to get a better view of the pedicle, and these are the 2 screws that have been put in. It is always better to keep both the screws at the same level so that the rod that goes in subsequently can be inserted very well. You have to understand that the lateral orientation of all the vertebrae is different as per the level you want to approach. The best way to know what is the position of the vertebrae is to take a lateral image on the C-arm once the patient has been given a final position on the table with a needle as a marker which is perpendicular to the floor. So you understand the relative position of the pedicles as compared to the vertical to the floor, and accordingly adjust your pedicle screws. In multiple levels, as in this case where we wanted to put in screws, as you can see, all of these are aligned on a straight line. If you have a screw that is off center, your rod which is straight is not going to negotiate that. You need to have all of these screws aligned straight so that you can give this secure fixation. Well, another easier way of doing it is to use navigation, where, as you can see here, you can have a 2D or a 3D navigation. I use an OARM based 3D navigation, which is probably the safest, where in 3 dimension you can get a very optimal entry point. You can make your percute screw entry there. You can measure your screw accurately. As you can see, I can get an optimal length of the screw inside. I can also measure the exact thickness of the screw that I can pass, especially true in the dorsolumbar junction in frail, thin Indian women. You can also track each screw as it has been put inside. Well, how does it happen? This is an OARM device which is doing a CT scan, it's a portable CT scanner of the patient on the table, which then gets loaded on the navigation. And instead of looking at the patient while operating, this is a real-time photo while we are operating, we look at the screen to see where our instruments are going. Each of this instrument is navigated and is calibrated to be recognized by the navigation. How does it go about? Well, this is a real-time imaging. This is what I'm doing, and this is what it is projected on the screen. The blue line here is that needle. I'm marking what would be the optimal entry point on the skin so that I know where to take a skin cut to go in. If a point to note is the amount, how lateral it has gone. So that is the marking there. I'll just play it again. So, sorry. So that's the second once the marking has been done. I'm putting in the needle. While I'm doing this, you can watch the virtual projection. This is going through the junction into the deep fascia. That's the plunge of the needle. Each of this action is reflected here. Now that I'm seated here, it is stable. I'm measuring the length, optimal length of the pedicle screw that will go in. And once I know I've measured that, I'll start tapping it in. As I tap it in, I can see this needle migrate real time inside. It is as simple as that. One of the biggest fears of putting a pedicle screw is the radiation exposure. As you can see here, there is absolutely no exposure. And I'm seeing, in fact, in 3 dimensions as to how safely and how correctly the screw is going. You can similarly track other instruments like your tap, as you can see here, and a finally placed screw real time as you're putting in, making this surgery extremely safe. Well, this is what the future is going to be. And this is something that has to be learned in real time. When you use a Jamshedi needle, it's better to use a mallet than to push in with your hand, because the chances of plunging when you're trying to push it with your hand, especially in osteoporotic bones, is high. A mallet gives you a measured push to put it inside. Always check with the C-arm when you are in doubt. It is better to have one extra shoe than to have a wrongly placed screw. Always beware of the guide wire. That's the most dangerous instrument that you use in percutaneous screw placement. Always mark your landmarks on the skin so that you know where and what you're doing inside. Align your screws when you're doing it at multiple levels. Please take your time. There's nothing, again, like a fast surgery, but there are stupid surgeons who do fast surgeries. Thank you very much.
Make a standard midline posterior approach to the thoracic spine and dissect up to the transverse processes. Note the various anatomical marks for pedicle screw insertion. An ideal starting point is at 10 o'clock on the left side and 2 o'clock on the right side. Entry point lies at base of the superior articular facet at junction of lateral 1/3 and medial 2/3. The slope of lamina suggests the craniocaudal angulation. The Lanke probe is first directed laterally so as to avoid perforating the medial cortex. Initially advance up to the 20 mm mark. Now carefully remove the Lankeole and feel for all the walls of the pedicle, which are the superior wall, the medial wall, the inferior wall, the lateral wall, and also the depth of the pedicle. The initial 10 to 15 mm of the track is the most important track to feel for. We prefer to use a flexible ball tip probe for this, and it should fit snugly into that canal. Now reorient the Lenke awl so that the curved end now starts faces medially. The controlled hand, filling all the cancellous bone, go inside the 30 mm depth into the vertebral body. Again, feel all the four walls of the pedicle and the depth of the pedicle tract. We prefer to use flexible ball tip probe for this. This ball tip probe should be gently advanced with a very controlled hand so that the maximum depth of the pedicle tract can be achieved. It also gives an idea about the angulation at which the pedicle screw should be inserted. Now use the artery forceps and measure the depth of the track, and which gives the length of the screw. Our screw length came out to be 40 mm as measured. Now tap the pedicle track. The author prefers to under-tap the pedicle by 1 mm as compared to the final screw diameter. Tap up to the 25 mm mark, which actually is the real length of the pedicle. Again, feel all the four boundaries of the pedicle and the depth of the pedicle track. Any soft spot will indicate a pedicle breach. Now with a controlled hand, with a previously observed trajectory, insert the pedicle screw. The author always prefers to use the multi-axial or the polyaxial screws. The final tightening of this screw should be done with a backout screwdriver so as to prevent wobbling. Anterior perforation of the cortex can lead to vascular injury. Medial breach can lead to cord injury. The inferior breach at the pedicle will lead to root injury. Now we have cleared the opposite facet of all the capsular tissue, and here we can observe the medial and the lateral dimensions of the facet joint. A partial inferior facet osteotomy will enhance the fusion and also helps us identify the proper entry point. The diagram shows thoracic pedicle entry and trajectory points. The first step is to locate the base of the superior articular facet. On this base, mark the lateral 1/3 and medial 2/3 of the facet. This is now the correct entry point for the pedicle screw. Before any screw insertion, we should observe the medial and the lateral borders of the facet joint. We nibble the entry point till the cancellous bone starts bleeding. Make a pallet hole with the help of the entry awl. Next step, choose the Lenke awl with the curved side facing laterally, and slowly and gradually advance the Lenke awl inside the pedicle up to 25 mm mark. The values of the coronal angulation and the sagittal angulation for screw insertion is different for every spine region. The morphology of these pedicles should be studied preoperatively on CT scans and X-rays. Now direct the curved awl midly and advance up to 30 mm mark. Ball tip probe is used to feel the base and all four walls of the pedicle. Look for any soft breach. Now with a controlled gentle push, direct the probe into the full depth of the pedicle. Precisely measure the depth of the pedicle track. While tapping, maintain the coronal and the sagittal angulations chosen for the pedicle. It is very important to again feel for all the four walls and the depth. Look out for a soft point which may indicate a breach. During screw insertion, avoid any kind of wobbling and it will directly go into the pedicle track. The transverse process in thoracic spine can be nibbled out because during last turns it comes in the way. Always take a good fluoroscopic AP and lateral views to assess the correct position of the pedicle screws inserted. In AP view, the screw tip should never cross the midline, and in the lateral view, A should be in the desired trajectory according to the region involved.
Hey, welcome to the Wiroc Surgical Theatre, and I will be showing a demonstration of soft tissue lengthening in children with cerebral palsy. So usually the soft tissue lengthening, or known as single event multi-level surgery, because it is done at multi-levels, that is at the gastrosoleus, hamstrings, and often also at the hip level for the hip flexors. Hence, it's called a single event multi-level procedure. The ideal age for performing this procedure is between 3 years to around 12 years, with a peak at around 8 to 9 years, typically when the growth spurt occurs and the deformities progress. So usually these deformities are indicated in children with cerebral palsy, which have fixed deformities. Prior to the deformities getting fixed, these kids can be treated with botulinum toxin injection. So this is a diplegic child who's walking on toes, and here the lengthening would be performed for the gastrosoleus here. If we look at this hemiplegic child, he's right hemiplegic, and here the procedure would be performed again for the right gastroc and right hamstring. Or in this diplegic, where this child is walking with a crouch gait, here the procedure is only indicated for the hamstring muscles. So for the equinus deformity, the standard procedure is the Strayer's gastrosoleus recession. For the knee flexion deformity, usually the medial hamstring lengthening is performed. Rarely we need to lengthen the lateral hamstring, and at times lengthening the lateral hamstrings can cause recurvatum or weakness of hamstring muscles. Strictly no TA tenotomy should be performed in a child with cerebral palsy, as they can lead to an iatrogenic crouch gait. So let's proceed to the surgical video now. So the position of the child is supine. It can be done with or without tourniquet. In case of being done without tourniquet, an infiltration can be used to keep the surgical field as bloodless as possible. So the incision is just around 4-finger proximal to the knee joint line. It's a small, around 2 to 3 centimeter incision based on the height of the child to expose the medial hamstring muscle. So I have an assistant who's holding the knee, which will extend when required. So now I have exposed the semi-T. It's important to open the sheath of the muscle, and the level of lengthening is not at the tendon level, but it is where we see the musculotendinous junction. If you can see here, that you see the tendon and then you see the muscle belly behind. And that is the point where the lengthening is performed, where we have a muscle behind, not at the tendon level. It is not a tenotomy, it's an intramuscular lengthening. So here I have done the lengthening for the semi-T. So the next muscle here to lengthen is the semimembranosus muscle. It's a broad muscle, it's a multipinnate muscle, and you see the fascia over here. So this is just the fascia on the muscle which is lengthened, so to bring about lengthening. So this muscle is a broad muscle, as I mentioned, and it's multipinnate. So we have to go again all the way more on the lateral aspect here, extend our cut so that the maximum length can be achieved. Now the third muscle is the gracilis muscle, and for this the position of the leg is slightly changed. Now I have extended the leg, abducted it, and this is the gracilis, which will be felt more on the medial side, and again it's the same intramuscular lengthening here. So you see the muscle behind, the tendon is just slided after the lengthening part, and then I can check how much hamstring lengthening I have achieved. So now the next part of the procedure is correcting the equinus deformity. And for this, I'll be doing a gastrosoleus recession. The most safest zone is the zone 2. So the calf is divided into 3 zones. The proximal one is the zone 1, then the zone 2 and the zone 3. The safest is the zone 2. The zone 3 is the tendinous junction and the tendinous part, and no procedure should be done in the tendon part. So now the incision is usually posteromedial. I do not advocate a posterior midline incision because it causes irritation with the orthosis later. And a posteromedial incision helps us to also expose the tibialis posterior when there is an equinovarus deformity at times. So here I'm going to take a simple posteromedial incision. So it's a small, around 1 to 2 centimeters incision. That's the surgeon's choice, what amount of incision they have to take, and depending on the length of the child. The soft tissue, the fat, and the fascia and the fat is retracted. And what we see below is just the gastrosoleus muscle, which it has just formed the tendon. So at this point, the assistant has to extend the knee and hold the calf to correct the equinus deformity. And while the assistant is correcting the deformity, I'm just going to make a horizontal cut with a sharp, fresh blade on the gastroc so that it slides while correcting the equinus deformity. What I see behind is the soleus muscle now, and the white part is the soleal raphe. It's important to make a cut on the soleal raphe so that the deformity can be completely corrected again. So that's the final cut in the soleal raphe, and the layers, and further the wound is closed in layers. We see that we have achieved a very good equinus correction post this procedure. After correcting the hamstring as well as the equinus deformity, now a plaster is given. So it's a above knee cast, because the gastroc is the muscle which is crossing the knee joint, and it's important to give an above knee plaster. So while applying the plaster, first the knee is flexed and the ankle is fixed either in 5-degree dorsiflexion or in neutral position. Once the below knee part of the plaster sets, then the plaster can be extended above the knee with slight 5 degrees of flexion at the knee joint. The cast remains there for 3 weeks, and the child can weight bear in the plaster or also walk with a plaster shoe. The physiotherapy typically starts at post-op day 3. Let's look at this child, the pre and post-op. So this is the same child who underwent the gastrosoleus recession along with the hamstring, medial hamstring lengthening. And you see now at around 6-month post-op, he has a very good flat, almost a heel contact, and he's walking well. His knee is getting extended and his gait has improved drastically. So that's all for the surgical video. Thank you so much.
This surgical technique video will describe the adjunctive use of spring plate in open reduction and internal fixation of posterior acetabular wall fractures. Me or my colleagues have nothing relevant to disclose, and there were no potential conflict of interest. No external financial aid was received for conducting this study. Open reduction and internal fixation is indicated in displaced posterior wall fractures with an unstable hip joint, and also in fractures with marginal impaction and presence of retained intra-articular fracture fragments. As an alternative, non-operative treatment can be considered in stable hips and in extremely elderly patients with multiple comorbidities. In fractures presenting late and in elderly patients with severe osteoporosis and marginal impaction, primary arthroplasty can also be considered. The preoperative plan in this patient is to use a Cocker-Langenbeck approach in prone position. The fracture will be reduced anatomically and stabilized with a lag screw and a spring plate, further augmented by a 3.5 mm buttress plate. Prone positioning allows easy knee flexion to relax the sciatic nerve and also allows good access to fluoroscopy. However, it is difficult to perform a trochanteric flip osteotomy in prone position if required. Spring plates are small malleable implants that has claws at one end. A custom-made spring plate can be made from a 1/3 tubular plate. These implants are extremely useful in comminuted fractures with small fracture fragments, and it has been shown to enhance the strength of fixation. The pre-reduction X-ray and the CT scan shows the dislocated right femoral head with a large comminuted posterior acetabular wall fragment. The hip was urgently reduced in the OR within 6 hours of injury. Post-reduction CT scan shows the size of the posterior wall fragment, and as you can observe, there are no retained intra-articular fragments or marginal impaction. For this surgical procedure, you require the 3.5 mm plating system, power tools with a universal chuck and quick coupling, the ball spike pusher, and multiple K wires in various thickness. During the course of the surgical procedure, we will also use the blunt sciatic retractors to safely retract the sciatic nerve and expose the retroacetabular surface. Other reduction clamps can also be needed as required to achieve a satisfactory fracture reduction. The operative side is marked and a formal timeout is then performed. The patient is positioned prone with the hip extended to relax the sciatic nerve. A curved incision is made starting 10 centimeters distal to the greater trochanter, curving posteriorly at the tip of the trochanter towards the posterior superior iliac spine. The skin and subcutaneous tissues are incised and full thickness flaps are raised, exposing the underlying gluteus maximus muscle and the iliotibial band. The iliotibial band and the gluteus maximus muscle are split along the line of the muscle fibers. The iliotibial band is split sharply, whereas the gluteus maximus muscle can either be bluntly dissected or can be split by using an electrocautery. The gluteus maximus muscle is split in such a manner that you have a posterior 2/3 muscle belly supplied by the inferior gluteal artery and an anterior 1/3 of the muscle portion which is supplied by the superior gluteal artery. The split muscle bellies are then retracted to expose the layer of fat pad overlying the short external rotators. Gently teasing this layer of fat will lead you to the sciatic nerve and will expose the short external rotators of the hip joint. The sciatic nerve lies posterior to the gammali and the internal obturator muscle and anterior to the piriformis muscle between the greater trochanter and the ischial tuberosity. The nerve is found extensively contused in this case due to the injury. As you can observe, the nerve is relaxed as the hip is extended and the knee flexed. But once the positions are reversed, you can observe the nerve getting stretched out, and it is important to keep the knee flexed and hip extended throughout the surgical procedure to prevent inadvertent injury to the sciatic nerve. The sciatic nerve is isolated and protected by using 2 wire loops. It is extremely important to make sure that no traction is placed on the nerve. Once the nerve is safely isolated and protected, the short external rotator muscles can be tagged with sutures before elevating them from the posterior capsule. The quadratus muscle should be left untouched throughout the surgical procedure so as not to interfere with the blood supply to the femoral head. The short external rotators are then incised 1.5 to 2 centimeters proximal to their insertion, once again not to interfere with the blood supply to the femoral head. A blunt sciatic nerve retractor is now used under the short external rotators to retract the sciatic nerve and expose the retroacetabular surface. It is again important to use these blunt retractors only for brief periods to minimize iatrogenic injury to the sciatic nerve. The fractured posterior wall acetabular fragment can now be well appreciated. The fracture surface is cleared of debris and clots, and any presence of marginal impaction should be looked for at this point. Presence of retained articular fragments will require the head to be subluxated or dislocated. Once you have confirmed there is no marginal impaction or retained articular fragments, a K-wire is drilled into the fracture fragment to use as joystick for manipulation and fracture reduction. Once reduction is confirmed, the fragment is pinned in place with a couple of K-wires, making sure they do not violate the joint. The K-wire joystick is then removed. Provisional fracture reduction is checked, and the hip joint is taken through a range of motion to make sure the joint is free and there is no inadvertent joint penetration. The posterior wall requires rigid fixation considering the amount of forces transmitted across in the early part of rehabilitation. It has been shown that use of a spring plate in addition to a reconstruction plate significantly increases load to failure. A 3-volt convex pre-bent spring plate is used in this patient. The plate is positioned over the posterior wall and fixed using a single 3.5 mm Cortex screw into the posterior column. When tightened, fracture compression is achieved by the hooks, and additional spring plates, if required, can also be used according to fracture morphology. One should make sure the medial hooks of the spring plate do not project beyond the posterior wall fragment, which can then cause injury to the femoral head or the acetabular labrum. The K-wire is now removed and is then replaced by a 3.5 mm Cortex screw placed by the conventional lag screw technique. The pilot hole is drilled by using a 3.5 mm drill bit, followed by drilling of the thread hole using a 2.7 mm drill bit. The screw track is measured and then tapped. An appropriate length 3.5 mm Cortex screw is used as a lag screw to press the posterior wall fragment. Further stability is provided by using a 3.5 mm 6-volt pelvic reconstruction plate that is contoured appropriately. One should make sure to seat the plate properly over the fractured posterior wall to generate adequate compression and buttressing effect. Additional screws through the posterior wall can be placed through the plate. However, one should be careful to avoid intra-articular penetration when placing screws in the vicinity of the joint. A distal screw into the ischial tuberosity significantly improves the stability of the construct by virtue of its long length and excellent bone quality in this area. You should be careful to protect the sciatic nerve during insertion of the screw. Remaining screws are placed on either side of the fracture as required to complete fixation. Intraoperative Jude views are taken to confirm fracture reduction, joint congruency, and screw positions. Prone positioning allows excellent access to fluoroscopy compared to lateral positioning. Once fracture reduction and fixation are confirmed to be satisfactory, the posterior soft tissues can be closed. The wound is lavaged and the sciatic nerve is checked for any sort of impingement. The previously tagged gamelli and internal obturator muscles are now repaired back with sutures. The superior gemellus muscle was found ruptured in this patient due to the injury and was repaired back. A closed suction drain is used and the gluteus maximus muscle and the iliotibial band are repaired with running sutures, followed by closure of the subcutaneous tissue and skin. Postoperative pelvis AP and Jude views demonstrate excellent articular reduction at 6 weeks. Similar fracture patterns treated with the same technique, showing excellent radiological and clinical outcome at long-term follow-up. The described surgical technique was used in 27 patients who were assessed at a mean follow-up of 6.8 years. Patients with isolated posterior wall fractures with an unstable hip joint, reduced within 6 hours of injury, were included in the study. Radiological outcome assessed as per Marta's criteria showed excellent outcome in more than 70% patients. Anatomic reduction in the initial postoperative radiograph was obtained in 25 out of 27 patients, and there were no significant loss of reduction in follow-up. Clinical scoring showed excellent to very good outcomes in more than 80% of the patients, and degenerative arthritis was seen in one patient, avascular necrosis of the femoral head in another patient. The overall clinical and radiological outcome was excellent when compared to previously published studies in the literature.
Presenting titanium elastic nailing technique for tibia fracture by Dr. Chintan Doshi. Here is X-ray of 10-year-old boy with tibia fibula unstable fracture at same level. Patient is positioned supine on radiolucent table. C arm is shown from the contralateral side. Instruments required are appropriate size tens nails, curved and straight awl, 2 T-handles, plier and hammer, Harrington rod cutter, F-tool, general orthopedic instruments. Entry point markings are done as shown. 2 to 3 centimeters away from physis and approximately 2 centimeters on either side of the tibial tuberosity. All preparations are done prior to incision. Intramedullary diameter is measured on table with skin markings. Also, it can be measured on preoperative true size X-ray. Here intramedullary diameter is 8 millimeters. Each nail size is chosen as 40% of intramedullary diameter, so that 2 nails of same size occupies 80% of canal at fracture site, which is also the isthmus in this case. Nail length is marked by keeping it over the limb. Required length from entry point to distal metaphysis is identified and level of fracture site is marked on nail as shown here to plan maximum bending area on nail. Bending of nail is achieved as shown here. Bending is uniformly done by holding the tip in the plier and T-handle is kept at side of entry point on nail. The maximum height of curve should be at level of fracture site and maximum height should be 3 times the intramedullary diameter. Both the nails should be of same size and should be symmetrically bent. Both nails should be of same diameter, same length, and symmetrically bent. Each nail has uniform curvature as shown with 3 areas of important curves. First, tip is bent in a direction to maneuver into the distal fragment. Second, bent just adjacent to tip is to allow nail to bounce of opposite cortex while entering. Third is the maximum curvature in shaft for forming spindle at fracture site. Entry point markings are done as shown. 2 to 3 centimeters away from physis and approximately 2 centimeters on either side of the tibial tuberosity. Skin incision is taken and soft tissue dissection is done to reach the bone. Soft tissue dissection is done and bone marking entry point is reached. Awl is used to make entry into the cortex. Awl is entered with twisting movements to enter the medullary canal. Once the medullary canal is entered, then awl is tilted to 45 degrees to make a good path for tens nail to enter. Previously prepared titanium elastic nail is entered into entry point. Initially nail is entered with tip facing away from cortex and once inside the canal, the tip is then turned around to enter the medullary cavity. Once entered into the cavity, the tens nail is then advanced. Here it is important that nail is turned around so the tip does not perforate opposite cortex. The curve adjacent to the tip allows nail to bounce of the opposite cortex. Introduce one nail into the distal fragment first for reduction. The tip of the nail is advanced into the distal fragment and then can be turned around to achieve reduction as shown here. Second nail is then entered into the reduced fragment. While inserting second nail, it is important to avoid snaking effect. This is prevented by not allowing second nail to completely rotate over first nail. Both the nails are then entered to distal metaphysis level. Once entered to appropriate length, the spindle is formed at the fracture site to keep it reduced and stable till healing. Nails are then bent and cut. It is important to cut the nail flush to the cortex so as to prevent irritation from the nail in post-operative period. The protruding end of the nail under the skin is then gently hammered to remain flush to the cortex of metaphysis. Post-operative X-ray shows well-reduced fracture with titanium elastic nail.
sessions of video lectures is two videos. One is on ramp lesion repair and the other one is on radial tear to tunnel technique repair. The first presentation is on ramp lesion repair and what are the tips and tricks that I follow in my practice. This is my profile in brief. We all know about ramp lesions. They are meniscocapsular separations. They have been described in detail in these review article recently by Robert Laprade, and I would suggest all of us to go through this article. The incidence is anywhere between 30 to 40% of all ACL reconstructions, and this is what we see corroborating in our practices also. Almost around 30% of tears, especially when chronic, we see that they have these ramp lesions. These are missed if you do not do the evaluation through the posteromedial pouch and through the posteromedial portal. And this is what we're going to discuss in this presentation. So as I just said, ramp lesions are nothing but meniscocapsular separations. Ramp is the normal area of the meniscus. Whenever there is a tear in that area, we call it as a ramp lesion. This has been very well classified by Sandri Cote from Lyon, France, into 5 types. Type 1 is just a plain separation, and we see small rents in this area in quite a few cases, which are usually stable and don't need any repair. Type 1 is when it is involving the meniscocapsular junction and with a small tear. Type 2 is when there is a partial superior lesion. Type 3 when there is a partial inferior lesion. Type 4 is what is the typical tear which requires various tips and tricks, and that is what we're going to be discussing here, where there is a through and through tear at the meniscocapsular junction. And type 5 is when there is a double tear. So with this understanding of the classification, we need to know on the MRI, this can be picked up with this sort of a longitudinal signal at the level of the root and the meniscocapsular junction, usually associated with posterior medial tibial plateau edema. That should be the indicator for you to understand to look for ramp lesion arthroscopically. However, we are doing this in every case now. This is the Gilkish view. We go between the PCL and the medial femoral condyle. This is the right knee. In every case, we enter this posteromedial pouch, drop the knee to 90-degree flexion, get a needle from the posteromedial corner, and use this needle test in every case to make sure there is no ramp lesion. In situations where there is a tight knee, for example, this is the left knee which is extremely tight and it is difficult for me to enter the posteromedial corner. So what I do is I clear some of the soft tissues, shift the scope from the anterolateral portal to the anteromedial portal, like so, get a switching stick from the anterolateral portal, pass it through the area between the medial femoral condyle, PCL and the medial tibial spine, railroad the arthroscopy sheet through the switching stick, and then you can enter the posteromedial corner. So these are the tips and tricks for the entering the posteromedial corner. Sometimes you need to internal rotate the tibia in about 30-degree flexion and try to slightly force your way in. This maneuver of internal rotating the tibia subluxates the posterior tibia and allows you to enter this particular corner. This is how typically anterior arthroscopy is done, and you feel that the meniscus is stable. But if you enter, and every case, if you follow this protocol of entering the posteromedial corner, then you will realize that suddenly the incidence of ramp lesions in your practice is extremely high. And this is a classic example, a meniscus that appeared stable from front, but you can see a type 4 ramp lesion where there is a through and through tear. It's very important to now, once you start repairing this, to do the pie crusting. The tips that I follow is I feel for the joint line. Use an 18-gauge needle from the TUR set, distal to the joint line and direct it posteriorly like a tenotomy blade with gentle valgus given by the assistant. And like you can see in the video, you will see a very gradual opening and you will not get that dangerous sound if you follow these principles. So pie crusting is important for me in my practice, especially for these large tears which are extending through and through, because I am going to be employing all the techniques available for repairing this meniscus. That is all inside devices, inside out devices, suture lasso kind of devices, and therefore I need a nice visualization space so that there is no articular cartilage scuffing. So with this pie crusting, you will realize that the same tear is now much more visible, much more easily accessible and manageable. It is clearly exposing the posteromedial tibial plateau. Having done the pie crusting, being comfortable about visualizing this entire area, I would now like to share a few tips and tricks regarding creation of posteromedial portal and in fact posteromedial portals, because in my technique I utilize 2 portals. So this is typically the area in a left knee, for example, how the posteromedial corner looks. Now there is a confusion where you need to create them. I will try to give you a few slides as to what guidelines you need to follow. So if you create a portal that is too low, you risk injuring the saphenous nerve. If you create a portal that is too high, you risk injuring the medial head of the gastroc. So if you look at this triangle, typically from the Gilchrist view, when you enter into the posteromedial corner, you will see the gastroc fold, you will see the adductor fold, you will see the medial femoral condyle on one side and the semimembranosus fold. Now this, for example, is the right knee, and the triangle that forms between these folds, if you are within this triangle, you can be rest assured that you are unlikely to damage the nerve or any other important structures. Another trick is to turn off the OT lights, look for the trans-illumination, and make sure that your needle comes to the center of the trans-illumination. This again will help you visualize any nerve shadows that can help you, and you will be in a safe area. Now this is the short video of the technique that I use using the lasso-like devices. So the first spinal needle comes above the capsular fold. The second comes at the level of the joint line. Do not remove the needles, let them be in place. Create a incision. The above incision should ideally be horizontal like you see in this video and above the capsular fold. This allows the portal to be naturally closed by the capsular fold and there will be no synovial fistula. I then come with a small cannula above, something like a 5.5 mm and a switching stick from below. You then get a diamond rasp the capsular side thoroughly, rasp the meniscus side thoroughly, rasp the synovium, then get the shaver, use it in the reverse mode with the suction off, and again create a nice healing environment. Again, pour out some amount of the capsule. You then come with the ramp lasso. This is a fixed angle 25-degree lasso. For the right knee, you will use a left angled device. Pierce the capsular side, then pierce the meniscal side. The advantage of using this ramp lasso is that it comes with a preloaded number 0 fiber stick. So it's firm enough to be easily railroaded like you will see in this video. And once it is in the joint and touches the saline, it becomes like a fiber wire. Retrieve the suture from the cannula and tie a knot. Preferably tie multiple half inches kind of a knot. Do not use a sliding knot so that there is minimal abrasion of the meniscal and the capsular tissue. You start from the medial side and then keep progressing towards the midline. So this is a simple lasso-like device, spectrum-like device, which is actually 45 degree. That also can be used if you do not have this special lasso. Pierce the capsular side. When you are piercing the meniscal side, sometimes you might find resistance. You can use the hook probe like a counterforce and push the meniscal tissue to take a nice deep bite. Ethylon will be shuttled for a fiber wire, number 0, and again a knot is tied. So the idea of doing this first is that most of the times the capsular tissue is fallen down and this has been equated to a Bankart lesion. You need to elevate it up to the level of the meniscus tissue to then progress with other modalities, which you will see ahead. So having done the posterior stitches using the lasso-like devices, having got the capsular tissue to the level of the meniscus, now you can make sure that you repair the longitudinal component which is extending into the body. You can use simple devices like all-inside devices, ideally in a vertical mattress fashion, sometimes in a horizontal mattress fashion if you want to span a larger area. First, tie the superior surface. Do not forget to involve the under surface. So this is a reverse curved all-inside device which is going on the meniscal side first, then on the capsular side. And when you tighten this suture, you would have repaired the meniscotibial ligament and restored the meniscal flans. And that's a stable ramp repair using lasso-like devices and all-inside devices. What I more likely follow is using the all-inside devices for the longitudinal component. A few tips and tricks for the same. I place the hook probe from the corresponding opposite portal from the anterolateral portal. You can see the 2 portals that have been closed now. And the hook probe is pointing into the area where I need to get my needles out. And that is where I would take a safety incision. The safety incision has been clearly guided to us by Robert Laprade. You take a safety incision in the posteromedial area, incise the sartorius fascia first, do the blunt dissection, go in the plane between the behind the superficial MCL. You have a triangle which is formed by the posteromedial capsule in front, the medial head of the gastroc behind, and the semimembranosus inferiorly. Once you identify this triangle, place a spoon there. The hook probe is guiding you all throughout, which is the likely exit point of the needles. With this understanding, another tip is to use low profile cannulas, which can be turned 180 degree. So you can go on to the meniscal surface and to the undersurface of the capsule by turning the cannula. So this is the video of the patient. So you have taken stitches on top of the meniscus in a vertical mattress fashion, as you can see, and now you're coming on the undersurface. So the first needle is passed through the meniscus tissue, drop the knee to about 60-70 degree flexion, and that will allow the needle to come exactly being deflected from the spoon, and your assistant can pull on that needle. The second needle is passed to the capsular surface, again being pulled by the assistant, and you can see restoration of the meniscal flaunch. I tie the sutures immediately so that there is no confusion at the end of the procedure. This is another stitch being passed through the upper surface. It's a horizontal mattress stitch which is being passed, retrieved from behind, and immediately tied. At the level of the root, sometimes I would suggest that you do not use the inside-out devices. So right at the level of the root, if you feel there is still a rent left, you can use fast fix device first on the capsular surface, then on the meniscal surface. So you have used the lasso-like devices at the back. You have used the all-inside devices above and below the meniscus, and near the root, you have used the all-inside device like the fast fix. So this gives you a nice, stable ramp lesion repair. So the purpose of the study was to give you the tips and tricks which you need to have for dealing with all varieties of ramp lesion repairs. And if you're familiar with these three techniques, then you can manage most of these complicated lesions. Thank you.
Good morning, I'm Dr. Mandar Agashe. I'll be talking to you about the secured shelf acetabuloplasty for Perthes disease. This child was a 9-year-old child, had bilateral Perthes, of which one side was operated with a varus derotation osteotomy. Now has pain on the left side with restricted range of motion. If you see the X-ray, he has Elizabethtown stage 2B Perthes disease with an extruded femoral head. We would like to cover that extruded femoral head. Patient positioning is supine with a bump under the ipsilateral buttock, which is the left buttock. The opposite limb is abducted and externally rotated. After painting and draping, towel clips are applied and a wide infiltration is given over the incision. This infiltration is with 0.5 cc adrenaline diluted in 100 cc of normal saline. After which, drape stitches are taken so as to remove all towel clips from the operative field. This is an extremely important step, otherwise the towel clips keep on coming in our C-arm view. A C-arm view is taken just to check, you can see the extrusion there, after which the incision is taken through the Smith-Peterson approach. This is a curvilinear incision extending from the middle of the iliac crest down to about 5 centimeters distal to the anterior superior iliac spine. Superficial dissection is done with the help of a mop, after which we try to identify the Smith-Peterson interval. You can see the color change between the tensor fasciata and the sartorius, between which will lie the lateral cutaneous nerve of the thigh. The fascia is cut with a small incision, after which it is spread with the help of a sharp dissecting scissor. You can see that the sartorius is there, and on the lateral side where my finger is the Smith-Peterson interval, which will be between the sartorius and the tensor fasciata. This interval is widely spread out right till the distal end of the incision, and you can see you can identify the various twigs of the lateral cutaneous nerve of the thigh, whose main body has been identified like this. This is then retracted out of our sight. We then go to the next layer, which is the layer between the rectus femoris at the center, which is the straight head, the iliacus on the medial side, and the gluteus on the lateral side. Here the plane is made between the rectus femoris and the gluteus medius. The rectus femoris is present on the medial end of the retraction. Once the rectus femoris is identified, then with the help of a diathermy, the periosteum is released from the anterior inferior iliac spine to the anterior superior iliac spine. This step really helps us with the splitting of the apophysis, which will come in a couple of minutes. Alright, after which, superior to the anterior superior iliac spine, we start releasing the external oblique aponeurosis of the iliac crest. There will be small amount of bleeders which are caught in order to achieve good amount of hemostasis and minimize blood loss. After which, with a sharp 15 number blade, the apophysis is split starting distally from the anterior inferior iliac spine till the anterior superior iliac spine, and then going posteriorly along the crest. I usually hold the crest with the two fingers so as to know exactly the midpoint of the crest, so as to achieve good splitting of the iliac crest. Then once this is done, with the help of a mop, we can just pop open the iliac crest with the apophysis like so, and by using mild pressure on that mop, we can ensure that there is almost a bloodless field and the entire crest is opened from the anterior superior iliac spine almost right till the greater sciatic notch. The abductor capsule interval is then identified. Before this, always remember there are a few nutrient arteries which have to be identified and burned, and on the iliac crest side they can be hemostasized with the help of bone wax. The abductor capsule interval is then seen, and all the abductors of the capsule are completely released so as to show the glistening white capsule. Once we reach near the crest, you can identify the reflected head of the rectus femoris, which is attached on the supraacetabular ridge, extending from the straight head of the rectus right till the greater sciatic notch. This is then looped with the help of a mixture or a right angled clamp. It is tagged with number 1 vicryl. And this is then clipped with the help of an artery hemostat. This is released from the straight head of the rectus and slowly erased off the capsule. All this while, it is important to ensure that we do not enter the hip capsule at all. After which we can clearly identify the supraacetabular ridge, and this is where our shelf is going to be. In order to achieve good retraction, we put a humans in the sciatic notch and start drilling the first drill holes. These drill holes are right in the supraacetabular notch, starting from posterior to the anterior portion, and then we start the osteotomy. Now this is just on the supraacetabular ridge and directed at 20 degrees of angle. As you can see in the fluoroscopic image, this is the exact way the image should be. This notch is then dilated with the help of osteotomes, which are placed one on another, so as to achieve a slot which is about 4 millimeters in thickness. This notch is about 3 to 4 centimeters in full length. After which we create these slots. These are slots which are marked on the superior border of the iliac crest, which we can then cut with the help of a saw. These slots are approximately 1 centimeters in diameter and they extend to about 2/3 of the thickness of the crest, like so, which are then peeled off the iliac crest. Cancellous graft is then removed from the inner surface of the iliac crest. Even in a small kid, you get good amount of cancellous bone if you do it this way. The graft is then prepared. We require a thin portion which will go inside the crest and a thick portion which comes out, so as to achieve a good thick shelf. These are then placed in the supraacetabular notch which has been created, and a 5-hole recon plate is then bent at around 90 degrees of angle, which is to be placed on the shelf. Now this helps really in securing the shelf and preventing it from withering off. This is placed on the anterior 2/3 of the iliac crest, like this. The point is marked where the screw will be, and a bicortical drill is made, taking care that it never plunges beyond it. The screw is then placed. Usually this becomes secure with just 2 good bicortical screws. The bone around it is then drilled, the outer cortex, so as to achieve good apposition for the bone grafting. The reflected head of rectus is then resutured back to the straight head, so as to achieve one more check-reen for the graft to not to wither off. After which the cancellous graft is packed on it. This creates an excellent coverage on the femoral head. And you can see the final C-arm picture. This is a final picture clinically, and this is a final C-arm picture showing excellent coverage. The apophysis is then sutured with the help of number 1 vicryl, and the skin is sutured in the usual way. Usually no drain is required for this procedure, as hemostasis is achieved during the same thing. The final X-ray picture shows an excellent coverage. You can see The graft is well placed and the plate also shows excellent correction. Thank you very much.
Good morning, friends and seniors. I'm going to share my views on MIS calcaneus. I'm thankful to the organizing committee for giving me this opportunity to share my work on this prestigious platform. The main indication for this fracture are Sanders type 2 and 3. Trauma should be within 1 week and the skin condition should be good. Preoperative workup includes various x-rays like axial view, lateral view, Rodin's view, ankle mortise view, AP view of the foot to see the anterior extension of the fracture lines into the calcaneal region. CT scan will be helpful for determining the fracture pattern and also to classify the fracture as per Sanders classification. As such, approach has described two main patterns. As we know, facet depression type and another is tongue depression type. Various CT scan images will give us some idea about the fracture pattern. Coronal view will give us the interarticular fracture pattern, heel widening. Axial view will give us the varus alignment of the tuberosity, also the anterior extension of the fracture line into calcaneal region, while the sagittal view will give us idea regarding facet depression. As per Sanders classification, we can divide this fracture into four main types. Type 1 will be minimal displaced fracture. Type 2 will be when there are two fragments of the facet. Type 3 will when there are three fragments of the posterior facet. And type 4 when there is multi-fragmentary fracture pattern. We should keep in mind the Gisson angle and Bohler's angle. These are the angles which will show the reduction quality of our fracture. We can imagine a person sitting on a beach chair in a relaxing mood. The angle formed is around 135, that is Gisson angle. Our goal is to achieve the length, height and width of the calcaneum. These are the various armamentarium instruments in our armamentarium like Sange pin, K-wire, bone spike, periosteum elevator, intervenous distractor and lamina spreader. The patient will be taken to lateral decubitus position with a sandbag under the affected leg. Tourniquet use is desirable. C-arm will be positioned in such a way that we can shoot AP view and axial view easily. The bony landmark for the incisions are tip of the lateral malleus and the base of fourth metatarsal. A stud incision is placed just beneath the lateral malleus, directing towards the base of the fourth metatarsal. These are the bony landmarks, tip of lateral malleus and base of the fourth metatarsal. The stud incision line will be placed just beneath the lateral malleus, as you can see in this video. It's about 3.5 centimeter incision. Now we will dissect ischemic and subcutaneous tissue in a same line. We identify the cerebral nerve and the small saphenous vein and retract them safely. Next step will be to dissect the perineal sheath and retract the tendons posteriorly. We will identify the external jejunum brevis muscle and we will reflect it plantarwards and distally. Now you can see in the video that perineal tendons have been retracted downwards. Now we will identify the calcaneofibrotic ligament. And we should try to preserve this ligament. Usually we don't cut in synostosis approach. After retracting the perineal tendons, we will see the depressed facet fragment. As you can see in the inset, a posterior pin has been placed to elevate this facet fragment. Now this is a tongue depression variety. As you can see, a pin in the posterior facet, tongue fragment, and how we elevate this tongue fragment with access approach the manure. When it's a facet depression type of variety, we can elevate with a broad periosteal elevator, as you can see in this video. I am elevating the depressed facet. Another method is to put a posterior pin from the tuberosity by making multiple drill holes and joining them together and make a vertical slit. Then pass a K-wire and elevate the facet as we elevate in Essex laparoscopy method. Now we will fix this elevated facet fragment with a temporary K-wire holding this elevated facet to the medial sustainable fragment. So now the K-wire has been placed to fix the facet fragment. Now we will proceed for the correction of the field varus. We will identify in the axial view a transverse pin has been placed to correct the varus and a temporary K-wire has been inserted from tuberosity fragment to the medial sustainable fragment. There are various methods described to correct this heel varus. One is to put a lateral to medial pin, another is to put a posterior to anterior pin. Either again we can use a Weber's clamp also, as is described in Fernandez method. After achieving the medial wall reduction, we will pass a K-wire to hold this elevated to hold this reduction in proper position. When there are multiple fragments of the posterior facet, we can use barbecue technique. In this technique, we take out the loose fragments of the posterior facet and we thread them into a K-wire and then deposit back into the remaining constant sustainable fragment, and then we will proceed for the fixation of this posterior facet fragment. The direction of the thalamic screw will be lateral to medial, directing toward the sustainable fragment, posterior to anterior and capillate to caudate to catch hold the sustainable fragment. Now we are proceeding for the fixation of the thalamic screw. Wire has been placed. Now we proceed. We will make a drill hole over this wire. This is a calibrated drill bit of 3.2 mm. Now we proceed for the screw fixation. The appropriate size screw, calibrated screw has been taken. We should pass a periosteal elevator or a small periosteal elevator to feel the reduction of the posterior facet. We can feel an articular step. There should be no step, and we can feel by passing this periosteal elevator in the joint. Another K-wire is passed to fix the fractured anterolateral fragment of the calcaneus. A 2.7 mm drill bit is inserted. A screw has been placed over this drill hole. You can see the screw in the images. Now we will proceed for a fixation of the PA screw. Another wire is passed from posterior to anterior direction from tuberosity, aiming toward the anterior process of the calcaneus. screw has been passed for this drilled hole. This is the final image. We can see the various screw. One is thalamic screw, another is kickstand screw to support the elevated facet fragment. This screw will be passed from tuberosity aiming toward the facet fragment, and we confirm it in the APN lateral, APN axial view that exactly it should support the elevated facet fragment. Another screw is PA screw to maintain the length of the calcaneus. Now we will see some cases. The young male, history of fall from height, sustained bilateral fracture calcaneum. This patient was operated on the 4th day of the injury by putting multiple screws with the method described. Just I described the method. Broadens view to assess the facet reduction. We will take Broadens view in 10, 20, 30 and 40 degree by rotating the X-ray tube. This is the 2 months post-op X-ray, 3 months post-op follow-up. This 15-month follow-up of the same patient. These are clinical images. These are the incision marks. This is the clinical photograph. Another case, a tongue dip type of depression fracture. After putting the incision, we identify the peroneal nerve tendons, the calcaneofibular ligament. This is depressed facet fragment, which was elevated by SS laparoscopy method. Temporary fixation of the posterior facet. Fixation with multiple screws. This is the Broadens view post-op. This is the clinical picture. Another case, a thalamic depression type of fracture pattern. Young male. These are CT images showing the depressed facet fragment. Here I used a plate because there was too much heel widening. The plate was inserted, a low profile plate was inserted with the same incision. This 2 months follow-up of the patient. This is the clinical image of the patient. This is a clinical image of the patient walking comfortably. Another case, a facet depression variety again. These are CT images of the patient. You can see the depressed facet fragment. Here a posterior pin was placed from the tuberosity, and the fragment was elevated with the help of this K-wire by joysticking. Temporary holding of the reduction with the help of wires. The axial image. Final fixation. Thank you.
चालू हो गया. This is juncta junctura. This is the cut end which has not retracted because of juncta junctura on both sides. This is the other side, and I am going to use to stabilize the tendon, needle passing through the substance of the main tendon. Here it is. Bas, thank you. Threaded tendon ends. Normally we do it with the 15 number blade, but this scissor is really good, so I am using it, and you can see the tendon ends have been sharpened. This one I did earlier. You can see it is well sharpened and prepared and freshened, I would say, not sharp. Okay, thank you. Modified Kessler suture, just lift it up like this, and it will be a longitudinal suture in the center of the tendon. I'm not holding the tendon with the forceps. I'm just stabilizing it, that we need to make sure. Sorry, I need to go again. Actually, it came a little more way. It is central of the tendon which we need to go and come out nearly on the dorsal aspect near the center here. This is the first bite, a transverse cut. We have done it. Stop, please. Longitudinal, which will go deeper to the transverse one. Here, come. One more minute. And coming almost at the same level where we entered. Now this is the suture which will hold the tendon end together. See this way. Now we do the same thing, repeat this same thing on the other side. Stop. The approximately center, and it goes deep in and comes out on the dorsal aspect. Here it comes out. Okay. One. Yellow. Yes. You can see it here. And if you want to hold with the tooth, then this is the place to hold, which I can hold it very well. Going towards the cut end and superficial to the longitudinal stitch, and here we come out. Done. Okay, done. Yeah, now we are going to take the longitudinal stitch, which will go deep to the transverse and will come out close to the 1 minute. Yeah, here it is coming out close to the previous stitch, the longitudinal one. And this is how we have completed the modified Kessler's bites. Just I'll take a scissor sister, same one, and I will just debride this which I was holding in case it is causing any. Done. Hold it. Now I will tie the, उठा लो सिस्टर इसका. Yes, double throw. Here we go. And good approximation is there. Done. To strengthen this, we have to take additional sutures, which we will take round and round, circular sutures all around, and this will give strength and smoothness to the repair. ये इसको ऐसे रखना. Just see. Yeah, okay. Put the small mosquito on top of that, sister. Aya? Okay. छोड़ दो. हल्का खींच. We will continue the repair from the other side, and I am passing the needle underneath the tendon onto the ulnar aspect, and here you can see how we can apply the stitches. You can see the under surface, and here we go. Done. Few more bites and then tendon repair is complete. This is the tendon substance. This is how it is going. And the last one will go inside and knot will be buried. This we do it with 4-0. Done. Now you see the external repair, smooth repair all around, and we will tie it here. Done. Only. Now you can see that the finger is not dropping anymore. There is no extension lag, and we need to check by moving the wrist, the tenodesis effect. The range of movement is the finger flexion, finger extension is all present.
Hello everybody. So this is a case of a Kienbock's disease, stage 3B Kienbock's disease. And you can see the X-ray, AP and oblique view in which you can see the sclerosis of the lunate. So we'll be doing a lunate excision and a scaphocapitate fusion through a dorsal midline standard approach for the wrist joint, and that's the surface marking of radial styloid and the ulnar styloid, and that's the midline incision just right centering over the Lister's tubercle. So after the skin and subcutaneous tissue, we reach the extensor retinaculum, and the EPL is the first tendon which needs to be identified and isolated. So the extensor retinaculum is cut in line with the EPL, and then you resect out the, you take out the EPL, and then you go down and reach the capsule. And the marking right now which I'm doing is marking of the dorsal capsule of the wrist joint in an inverted kind of a U shape, and we call it as a Berger's ligament sparing capsulotomy. It's a sharp capsulotomy which is done to reach the wrist joint, preserving all the ligaments. Make sure then when you preserve this capsulotomy incision and you repair it later on. So that is the capsulotomy which is being done right now. And make sure that you use a sharp dissection while doing this capsulotomy. And that's how sharply it's raised. And you can see how thick that capsule is. It's a very tough structure, and that's how it is raised very nicely. And down below you can see that there's a lunate bone. So make one's put one guide wire or a K wire into the center of the lunate to make sure that you identify it under C arm. That's where you see it. That's the dense sclerotic bone, and the guide wire is going into that, and that's how you identify it, that it's to make sure that you're into the lunate, and then that's the scapholunate ligament, which is being identified, and which is being transected right now, and that's you see the scapholunate interval. So the K wire is out now, and you can see the lunate, and that's the scapholunate interval. And make sure you nicely dissect it out without damaging the articular surface of the scaphoid. And this is one of the technique even which we have published recently on how to excise the carpal bones, especially when you're doing a proximal row carpectomy. And that's the small shunt spin which is going right into the lunate. You can see the color of the bone there. It's a dense bone which is coming out there when you're drilling it. So you get good control of the lunate by putting in a guide, putting in a small 3.5 millimeter shunt screw into the lunate, so that you can joystick it all around, and you can go 360 degrees all around the lunate. That's the scaphoid side, and that's the side of the tricutrum, and you sharply cut all the ligaments, and then you are very easily, very nicely, you'll be able to take out the lunate in a single piece. So it's very good in that way to resect, to take out the lunate in one piece rather than taking out in a piecemeal, because that becomes really a cumbersome activity, and sometimes some bits and pieces of the volar side capsule remain there. So that's how the lunate has been excised completely, and now it's time to go in and that's the volar some part of the capsule. There's a strong volar capsule, like we saw the dorsal capsule just few minutes back. So the volar capsule is equally tough structure, and sometimes the part of the remnant of the excised lunate can be there, and it's better to remove every bits and pieces of lunate which are there, because usually it's a fragmented lunate when we are dealing with this condition. So now this is the interval between the scaphoid and the capitate, and that's how you correct the rotation. See, that's the rotation of the scaphoid. It's a very important thing to note here, that whenever there's a collapse in the lunate, the scaphoid starts to tilt forwards, and that's what we call as a DC deformity, unlike the VC deformity which we have when there's a scaphoid non-union. So now you take a good blade. You should have a good instrumentation for this. That makes your life really easy. However, you can do it with a big saw as well, but then it's always better to take a small handheld saw, and that's the cut which is taken on the scaphoid side of the capitate bone, because here what we are doing is a scaphocapitate fusion. And that's the, nicely you take out the cartilage, and you see the rough subchondral bone, and now that's the part. This step is a little tricky because the scaphoid is not a straight bone, it's like a twisted kind of a peanut. So when you do this, you make sure that you take two cuts. One is it's like at an angle, maybe an obtuse angle to each other, and make sure that you've taken off all the cartilage. So this is another cut which is being taken, and make sure they are nice, parallel in shape, and remove all the volar aspect of the cartilage as well. Sometimes that remains there. And now have a look at both of your surfaces, both of the ends which needs to be fused. Make sure you get a good contact. And these are small carpal bones we're dealing with, and the fusion rate is extremely good if the contact between the two surfaces is good. You can use K wires at this moment. I must suggest, if you're not putting in screws, you can even use K wires, 2K wires, 1.5 millimeter or 1.2 millimeter, and you can get a good compression. I mean, and you can, however, when we are using K wires, we have to immobilize for a bit longer period. So right now what I'm doing is I'm trying to, put one guide wire, put a guide wire and another guide wire, so that there's an anti-rotation kind of a mechanism is there, and there's a good contact now. So this is one guide wire I'm pushing in from the radial side through a percutaneous type of a technique and going into the capitate, and then this is the drill. Make sure you're drilling it very in linear line with the guide wire. Sometimes these are spine guide wires and chances of breakage are there, and that's how, and that's a fully threaded headless compression screw which is being put now, and this is, of course, you have to check. In a couple of minutes, yeah, that's how the screw is gone. The other anti-wire is in place, anti-rotation wire, and that goes in the screw. And you have to feel it, like wherever we put an Herbert screw, we have to feel how the compression is. And then this is the second. I'm removing the anti-rotation wire, I'm passing the other guide wire, and then I'm passing the other screw on top of that. So if you manage to put two screws, I think you'll be really happy at the end of the day, because you are pretty sure that two Herbert screws, across these two bones, it gives a very good compression across the osteotomy. And then there is, I mean, you're sure that this is going to unite and this is going to heal. So that is, that's the K wire is out, and then and then you're checking the movement. That's perfect, and you'll be happy to see both the bones moving in one plane, and that's a good trajectory of the screw which is there. And that's the capsule which I was talking about. You can repair the capsule nicely. You do repair it back, and that's using some non-absorbable braided sutures are used to repair the dorsal capsule. So make sure you get a good airtight closure of the capsule, because that helps in stability, that helps in giving the vascularity, that helps in many ways in rehab, and getting back to the normal movements back. And that's the extensor tendons, and that is the second compartment, the big tendon which you see, and ECRL, ECRB, and that's the extensor retinaculum. You can if you have a good closure, you'll be happy at the end of the day. So that's closing the extensor retinaculum. So when you're putting in screws at this point, I must tell you that you're happy with mobilizing them pretty early, and that's you do a skin closure, and that's the post-operative X-ray. A good trajectory of the screws, crisscross crossing in both the planes, going into the these are fully threaded compression screws, and we get them along, not mobilizing them, or not. I personally do not immobilize them for a long time. So that is that is all about the technique of scaphocapitate fusion. Thank you so much.
So he's a 42-year-old male with pain in the left hip, and as you can see the AVN changes, there is arthritis in the left hip. So we're going to do a total hip replacement surgery.
First advantage we get is we get a complete 3D model of the patient's hip, okay, and you get a 3D reconstruction. And the second thing is we get to see the amount of lengthening or shortening of the hip beforehand, before going into the procedure. So in this particular hip you can see that it is 2 millimeters longer than the opposite hip. After doing the surgery, we can again reassess and see how much longer or shorter we are compared to the opposite hip, and we can also see how much longer or shorter we are compared with the preoperative hip. Okay, so this is the first amount of information that we get with the robot. So next thing is, let's go to the acetabular planning. We get to plan the acetabular cup. Now, as a default, we put this in 40 degrees of inclination and 20 degrees of anteversion, as this is what we usually aim for. Okay, now let's go to this is this 3D view. We can rotate it and have a look. Rotate it away. And you can see how it's nicely fitting, how much of uncoverage is there, and everything you can see over here. Now you see these two dots. The pink dot is the native center of hip, and the green dot is the center of the cup that we have placed in. As you can see, the cup is slightly superior to what was native. So you can see here also 2 millimeters superior to what is native. So let's go to the cup planning stage. Okay, mind you, this is all still preoperatively. This is all done beforehand. A CT scan is taken of the patient, and this is done by the macro product specialist, where they take the segments and then they give you as a default, and we can do modifications once we go into the theater. Now the first thing is we see a transverse view of the acetabulum. We can see whether it's nicely matching the magenta line of the bone, and this seems to be pretty good, but I would probably like it to be slightly more medial. So can you medialize my cup please? A couple more clicks, 2 more clicks. Yeah, I think I'm a little more comfortable like this, maybe even 1 more click. Yeah, now scroll through please. You can see it's nicely fitting in the magenta line. That will have a nice hold. This is a trident hemispherical cup, and the size 50 is matching nicely to the magenta line. Now let's go to the next view. Because we go to the sagittal view. Scroll through again please. Again, it's nicely matching this magenta line. Come down. So I'm quite happy in the sagittal view. And then the coronal view. Again, scroll through. Yep, come down, and looks superior inferiorly also looks like a very nice hold. Go up again. Scroll up and come back down. Wonderful. So this is what I would probably prefer for my cup. Size 50 with this particular positioning. 40 degrees inclination, 20 degrees anteversion, 2 millimeters superior and 1 millimeter medial to the native hip. I'll show you what happens if I change my anteversion depending on my, let's say my femoral anteversion was less than what I wanted. If it's neutral or even retroverted, I can change my cup anteversion to 25. And now you see it's slightly changed over here. Right? Now bring it back to 20 please. Right. Okay, and now I can see the same visualization of this particular cup on the X-ray. Can you go to the X-ray view? Look at that, it's nicely near the teardrop and looks quite good, sitting on the quadrilateral plate. So this looks like a very good pre-op visualization of my post-op X-ray. So this part is done. The acetabulum at the moment I'm quite happy with. Now let's go to the femur. Okay, the femur, the first thing I can do is I can see my stem size. Now we don't have to be married to this particular thing. It gives us an idea. We do find usually like a variance of 1 up or 1 down to what is planned. You can see that a nice snug fit of this accolade 2 stem is coming to a size 3 stem, and it does show that my femoral anteversion is probably negative, it's retroverted. So I would probably want to change my acetabular anteversion to another +5. Can you go back to my acetabulum? Make it 25 degrees, and we can recheck it once we go intraoperatively and see whether we need to change it or not. Okay, come back to the femur. So now you notice over here we had 2 millimeters of lengthening preoperatively, so now we have managed to get it to the equal length. So by using a 132 degree neck and a 0 mm head of a 32 mm size, let's show you what happens if I use a high offset. Let's change this to 127 degrees. This has changed, and now you notice that we have got 3 millimeters shorter. Right? So these are all the different things that you can play around with. And now if I want to increase my head length to make it a +4, it goes 1 millimeter longer. Okay, so let's go back to 132 and a neutral head. So as a default, I'm going to start off with this. It's a size 3 stem with a 132 degree neck and a 0 mm head. Okay, so this is my plan. Let's go to the next screen, please. This is a visualization of the implantation. So this is the cup that we planned with a 25 degrees anteversion, with the head, which is 32 millimeters head, neutral head, and a size 3 neck with a 132 degrees neck. And this has become equal to the opposite side and 2 millimeters shorter than the pre-op. Okay, that's what we have planned out. Right, and this is a pre-op visualization of the post-operative X-ray that looks absolutely beautiful, and this is what we want to replicate post-operative. Right, now I'm just going to show you how the OT setup is going to look like with the Mako total hip. So my position of the patient is my regular lateral position. I still go for a posterior lateral approach. I'm standing on the normal side behind the patient. And if you notice, all the trays and all my myotrolleys are on my side. The robot comes to the opposite side. Okay, is on contralateral side. I have a monitor here for visualization. And this is my camera, which is going to be right at the head end of the patient, and it will be reading the arrays which I am going to place over here. Apart from these, the Mako product specialist will be standing over there. Okay, that's the console where he will be working from. The same thing on his screen will be showing to me on this screen over here. So this is my OT setup. The first difference over here is we have to make sure that you are exposed up to the iliac crest, because this is where we are going to put in our pelvic arrays. Okay, so you will try to find the anterosuperior iliac spine, and then you take around 3 to 4 stab incision. Test. Right. So once you have put these 3 array pins in, okay, this gets slotted over, tighten it over here, and these are my visa discs. Okay, this is what the camera of the robot is supposed to read. So you place it over here. You have to rotate. It's very important that you tighten all of these so they don't move during the case. See, my arrays are visible to the camera, and if you look at the screen, there's a blue dot in all the 3 planes that shows that it's visible. Now if you cover it with my hand, that disappears. If I remove that, you can see that again. And if you see in the top right hand corner, there's a green box which shows that my pelvic arrays are visible. Again, with my hand it disappears, and without my hand it reappears. Okay? We have exposed the femoral head and the neck, but before I dislocate, I need to do one step which we will not usually do in a conventional case. I need to relocate it back, make sure that I am not dislocated. Okay, find one spot on the greater trochanter, a nice prominent spot. Here a small space there. This is something known as the femoral checkpoint. Okay, I'm going to insert this onto that point. Okay, so this checkpoint is going to help in my determination of my shortening or lengthening of the femur, so that it matches the opposite limb, okay, which is below. The opposite limb is now strapped in with a sticking tape, and I match the heel to the heel. Okay, the way we check for the length clinically. Okay, so my knees are matching. If you see here on the lateral femoral condyle, I have an ECG lead. Okay, so now I take something known as the blue probe. First I capture this point, capture, thank you. And then I go and capture the ECG lead, capture. Okay, so now my native length has been entered by the robot, into the robot, and all future measurements should be in the same position. Another bit of information I can get is how far from the lesser trochanter I need to take my neck cut. So if you can see over here, it's showing 2 centimeters of almost. This is my, from the top of the LD, right, from where we will probably take our neck cut. Now we need to clear up the reflected head of the rectus femoris, just so that we can expose a bit of the supraacetabular portion.
we need to place something known as the acetabular checkpoint over here. Okay, checkpoint please. This will be a reference point for future steps, further steps of the case. So this goes into the supraacetabular area. Steady. Now this blue probe comes and sits in this. Make sure it's visible to the camera. Capture and take it out, put it back in, verify. Now this point will be our reference point in the future to check if anything has moved. Okay, so now you can get it out of this. Yeah, it's important that we remove our labrum and our pulvinar like we do in regular cases, because we need to register the acetabulum now, and for that we need to clear it out completely. The next step is the registration of the acetabulum. If you can see, I have a foot pedal over here, a blue probe. Now this step in essence is going to now confirm to the robot that whatever CT scan was fed into it is matching exactly to the real anatomy of the patient. Now this mega bubbles that you see over there, these should match exactly to the anatomy of the patient. So let's see, this is somewhere in posterior, so I'm going to place it over here and take my first reading. The second one is anterior. You try to match it to whatever bony prominences you can see on the CT scan. There's a bit of a bone projection over here right in front of the bubble. The same intraoperatively. There you go. Okay, now I have 32 points within the acetabulum I need to feed into the robot. So now you have to take 4 in the front, in the anterior horn. Most important thing here is we have to pierce the cartilage and reach the cortical bone. It's very important to reach the bone. The depth is more important than the exact position of the probe. Now inside the fovea, 2 points, and the rest of the points are outside the acetabulum. Again, remember, I'm trying to reach till the bone. So if you have some soft tissue, you have to pierce through until you reach the bone. The position doesn't have to be exact, but the depth has to be exact. The last 5 points. Important thing is, if you see that accuracy over there on the screen, it should be less than 0.5 millimeters of accuracy. Here I'm on 0.3, so that's acceptable. Now I have to reconfirm these bubbles. This is again back to the 3D anatomy of the patient itself. You have to reach the bubble. There are 3 important things. First thing, the visa disc should be visible to the camera. Let's say if it's not visible, you can see it's become red over there, and if it's visible, it becomes green again. So that's the first criteria. Second criteria, you have to be in the correct position now. So if I'm in the correct position, you can see that the bubble turns translucent. Okay, the third important thing is that wording that says distance to bone, it should turn green. When I'm not on the right depth, it will be white. When I reach the right depth, it turns green. So all these 3 criteria should be met before the bubble can be burst. So that's the first. The second. That's it. So now my robot knows exactly where the acetabulum is. The rest of it, the robot takes over. It helps me out, and my assistant on my side helps to hold the anterior horns so that the robot has space to come in. You now see the robot comes in to place. The robot has its own arrays. This should also be visible to the camera. Over here, you can see these arrays. This is my reamer. My planned size of cup is 50 millimeters. So because I'm going to do a single ream, I have to take 1 reamer size less than what we have planned in the cup. So 50 cup size, I'm going for a 49 reamer. Now you can see I have to reiterate to my robot where is the robotic arm. Okay, right. Now it's telling me where I'm supposed to read. Can you rotate these to me? Okay, so now this is not locked, this is a conical haptic. It's going to allow me to move around to a certain extent, and the green is telling me which part I'm supposed to read more. So obviously a little more superior, a little more medial. I'm going to start reading now. As you can see, slowly the green starts to disappear. That's it. And if you see medial, it says I need to go one more. So I'm just going to rotate up. That's it. I've come to 0. That's it. 0, 0, 0. Perfect. So my ream is done. A single ream and I'm done. Bring it out. As you can see, single ream. I've taken out all my excess bone which I don't need. You can see a beautifully reamed with a single ream. I did not have to do serial reaming. One single ream and I get my perfect hemisphere. Okay, so I mentioned about the single ream. The impaction also is a single impaction. I don't need to do trials again. So 50 cup is what we planned. Can you get my 50 cup? I got my 50 cup. Okay. First what I do is I take it and I try to place it within my acetabulum. And then I attach my robotic arm. Okay. This black disc should be visible throughout. So what I do is I take it close to what my actual planned readings are. So around 46 degrees and bring it to. Okay, can you lock now? Now I leave it and the robot is auto locked into what I had planned. You can see that. Okay. There you go. So it's auto locked into 40 degrees and 25 degrees. It's not going to move now. This haptic is locked haptic, unlike the reaming. Right? I'm going to the other side to impact. As I mentioned earlier, the black disc should be visible. Okay. Now, capture. If you see there, it says 12 proud. Okay, now, capture again. Yeah, 11 proud. Now, piece. It's going in. Right. Capture. 10 proud. Capture. 8 proud. Capture. 5 proud. Capture. 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 That's it. So I've now completely impacted my cup. The robo goes out. You see, my cup is perfectly impacted with just a single impaction. I did not have to trial. I'm just going to show you the hold of the cup. That's a rock solid hold. Okay. So I'm not even going to put any screws in. Now the beauty is I can recheck my values. If you can see these concentric circles within the cup, I take 5 points on any one concentric circle to recheck my version and my inclination. Capture. 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 There you go. You can see the screen now, exactly 40 degrees inclination and 24 degrees of version. Just for demonstration, we usually take our transverse acetabular ligament as a reference point for antiversion. And if you notice, if you remember, we had kept our cup in around 5 degrees of antiversion compared to normal. So around 25 degrees. So this is exactly showing that our cup is around 5 degrees antiverted to the TALs. So that's what we had planned for. As per our plan, we had size 3 and this looks like a decent fit. It's not going down further. So let's trial with the size 3. 132 degree neck as per the plan. Yeah, now I am putting the neck on. As per our plan, again we had a neutral head. So let's get a 0. This is 32 millimeters neutral head. Yeah, I've reduced my femur as you can see over here. Now extension is good. External rotation is good. Flexion is good. And internal rotation is good. It's dislocated only after this. Can you go to neutral and give me a shock test? Shock. Yeah, it's too loose. So again, I'm matching my limb to the opposite limb. Capture. Capture. So I'm still 6 millimeters shorter if you can see the screen. So, and I also do feel that the stability is not so great. I'm now planning to keep a little prouder stem. So I'm going to take out my size 3 and for a size 4 stem to keep it a little prouder. This is fairly easy. Should it? Okay, let's have it. Better, but still kind of loose. With a size 4 and a neutral head, you got good stability. Okay, now I'm going to check my length again. Capture. Capture. There. Now it shows that I'm 3 millimeters longer. Capture. Beautiful. So now, if you noticed, because my offset had reduced a lot with the 132 degrees, I put in a 127 degrees and that has a higher offset, and that's helped to reduce my mismatch in the offset and also brought my lengthening down. So this feels much more stable with the 127 degrees neck. I'm going to go ahead with a 4 stem with 127 neck and a neutral head. .32 mm neutral head ceramic. Yes. Cool. External rotate. Yes, that's it. Very good. Final check after implantation. Capture. Capture. That's very nice. So we'll accept this.
Performed either using an posterolateral intertransverse lumbar fusion. This is a fusion procedure which involves immobilizing adjacent vertebral segments by fusing two adjacent vertebrae in the posterolateral gutter, that is in the intertransverse region. What are the advantages of an intertransverse lumbar fusion over other fusion techniques? It has a large muscle envelope over which covers the fusion, and therefore there is an excellent blood supply. It is closer to the weight bearing axis compared to posterior spinal fusions, hence the fusion rates are superior. It can be performed even when a central decompression has been done. Because you're not exposing or manipulating neural elements much, the risk of dural and neurological injury is much lesser. The disadvantages are, in order to get well lateral so as to do the fusion, a longer skin incision is required. There is more muscle dissection, more blood loss, there is possibly more post-operative pain and a longer rehabilitation period. It also carries a slightly higher risk of pseudoarthrosis compared to an interbody fusion. The technique is mainly that of a standard lumbar lumbar decompression fusion procedure. But the three key steps which differ are the extent of exposure, the procedure of decortication, and the procedure of laying bone graft in the posterolateral gutter. The positioning is a standard lumbar spine procedure. I use horizontal bolsters placed below the iliac bone and below the lower thorax to decompress the abdomen. The incision is usually a standard posterior midline incision, a little longer than the usual incision because you need to go laterally. You can also do this fusion via a paramedian approach, which is also called when you are using the Wilsey paraspinal splitting approach. The exposure is done in two stages. The first initial exposure involves exposure up to the facet joints, and then maintaining the facetal capsules. One then goes dissects outwards up to the tip of the transverse processes, as shown over here. The third step in this procedure is a decortication, where we decorticate the bone in order to expose the cancellous bone, which then serves as the graft bed. The graft is then laid in the posterolateral gutter as close to the bone as possible. The pedicle screws are then inserted and the rods are assembled, and this is what the final construct looks like. Postoperatively, the patients are mobilized with a frame type belt. Out of bed mobilization is allowed the same day. Activities are allowed as tolerated. I remove drain only after the daily blood loss is less than 50 cc, and active back exercises are started only after 3 months. Here is a patient.
Discussing the case of Lade Begum, an 82-year-old lady who presents to us with severe back pain and radicular pain down the right leg. The pain is accompanied by tingling and numbness, and her claudication distance is barely 5 minutes. She has severe bilateral osteoarthritis of the knees along with the spinal problem. The X-ray of the lumbar spine, as you can see, shows significant degenerative changes throughout the lumbar spine with mild degenerative scoliosis. The lateral views, which include the flexion extension views, show that there is a sacralized L5. L4 has an anterolisthesis over L5, whereas L3 is retrolisthesing over L4, and there is significant destruction of end plates and degeneration in this area. Going to the sagittal MRI, the cervical MRI shows no evidence of spinal cord compression, but if you look at the lumbar MRI, you can see that she has significant degeneration at L2, 3, 3, 4, 4, 5, and 5, 1, with prolisthesis at 5, 1 and a retrolisthesis at 4, 5. Going to the axial images over here, you can, starting from lower down, you can see that the lowermost level has significant stenosis, that is 5, 1, and as we go up, you can see there is significant stenosis at 4, 5 with synovitis of the facet joints. There is also significant stenosis at 3, 4, the facet joints are vertical, and even at 2, 3, the facet joints are vertical. So the plan today is to do a fusion which will extend from about L2 over here to S1, where we will start the procedure with a single midline posterior approach. We will expose the spine from L2 to S1 up to the tip of the transverse processes. We will then decorticate, because our plan is to do a posterolateral fusion. We will decorticate the transverse processes and the posterolateral gutter and insert pedicle screws at L2, L3, L4, L5, and S1. And having done that, we will then place bone graft in this entire region. Because this is an extensive decompression and fusion, I will be using autograft which is locally harvested along with allograft for the fusion. Thank you.
So it's a standard posterior midline incision. I then infiltrate this area with adrenaline saline. This incision, as you can see, standard posterior midline incision, expose right up to the spinous processes. I like to elevate the fat because it comes in the way of the dissection as well as the closure, and therefore elevate the fat slightly. If you elevate it too much, it creates a lot of dead space. The incision then proceeds dorsal fascia just lateral to the spinous processes, and then there is subperiosteal elevation of the muscles. I'm not going to go through the details of that, but the initial exposure involves exposure up to the pars interarticularis and facet joints. Then keeping the facetal capsule, the exposure goes laterally. You must stick to the bone. Always keep dissecting on bone laterally. Follow the facet laterally onto the pars interarticularis, onto the transverse process in order to reduce the bleeding. Just lateral to the facet joint are many bleeders, and if you stray, it may become very difficult to control the bleeding. Although the posterolateral fusion, because of the extent of exposure, can bleed a lot, if you are very careful with your dissection, you can limit the bleeding. This 5-level procedure from L1, L2 to S1 required only about 3.5 hours of surgery, and the blood loss was less than 500 cc. So you can see here we are exposing the lateral part just lateral to the facet joint, and then going right up to the tip of the transverse processes for exposure.
Discussing the case of Lade Begum, an 82-year-old.
So there you can see the exposure proceeding laterally. On bilateral, exposure is completed. And having completed the exposure, extensive exposure, always pack areas where you're not working so as to help hemostasis. Having exposed adequately, the next job is to do a decortication of this entire area. Where prior to the decortication, I like to remove the spinous processes of the levels which we are going to decompress so that bone graft can be prepared. And then using a drill, I start decortication. The decortications for a typical L4-5 intertransverse fusion would involve decorticating the lateral part of the L3-4 facet joint, the transverse process of L4, the pars interarticularis of L4, and then decorticating the L5 facet joint and the L5 transverse process in order to lay your graft in this graft bed. So that is a typical way in which you proceed, and you must always do it in a systematic manner. Stick to bone. You will get some bleeding in this area. You must control it with your bipolar or unipolar cautery. And having finished the decortication, you must then pack this area so as to control the bleeding. As you can see, proceeding right up to the tip of the transverse processes in a very systematic manner, decorticate so that you can see cancellous bone over which bone graft can be laid. Do not disturb the facetal capsule at the most cephalad level which you are fusing, because that is not a level which you are going to put though you're putting a pedicle screw there, you're not fusing that level. I like to do the decortication bilaterally so that the canal is not open when we are using high speed or sharp instruments. Decortication in the good old days used to be performed either using an osteotome, a nibbler, or a curette. But if you have access to a high speed drill, that is the best way of performing a decompression. We now establish the entry points for the pedicle screws. I like to establish the entry points, confirm the position of the screw tracks, and then tap the holes. I do not put pedicle screws at this instance. The reason being, I would first like to place a nice bone graft in the entire area. So there you can see I'm placing bone graft in the posterolateral gutter. And having laid this excellent bone graft over there, I then insert the pedicle screws. The rod is assembled on that side. I now start doing the decompression because I need the bone graft from the decompression for the fusion on the opposite side. So having done the decompression, here there was dense adhesions. It was a very tight stenosis, dense adhesions. I had a dural tear. However, when I have a dural tear, typically I just pack this dural tear and finish my decompression before I try to get the dural tear under control. So an adequate decompression has been performed. And once an adequate decompression has been performed, then it is time to do a similar procedure. Pedicle screw entry tracks are made on the opposite side. Bone graft is laid in the posterolateral gutter, and then the screws are inserted. You can see the rod being finally assembled over here. This is what the bone grafting looks like. I've used a muscle patch with fat pad in order to cover the dural defect. And that is how the posterolateral fusion looks. A nice graft bed and a nice fusion procedure. And this is what the X-ray looks like at the end. So remember that a posterolateral fusion is an excellent procedure. I use it very frequently in the setting of a degenerative spondylolisthesis or when I'm doing long fusions. In patients with lytic listhesis, where I'm doing a reduction of a listhesis, or when there is a degenerative listhesis with a disc prolapse or wide open disc spaces, I prefer an interbody fusion. Thank you very much.
I am Dr. Vasudev Gadegune presenting on trochanteric buttress plate with IM nail in fixation of unstable trochanteric fracture. These are all unstable fracture requires to be fixed by the augmentation plate along with the intramedullary nail to address the lateral wall. We require to have some reduction tools like T-handle, ball tip pusher, large pointed reduction forceps, Steinman pin, and Homan's retractor. This is the standard method under spinal anesthesia, close reduction on a fracture table, and you can reduce the fracture. Before that, we have to appreciate and visualize the proximal femur, appreciate the fracture pattern. Accordingly, we have to achieve the reduction. And eccentric supine position is very important because we have to adduct, abduct, internally rotate, and external rotation is required. Most of the fractures of unstable variety, they are reduced in external rotation rather than in the internal rotation. And this is the position of the patient on fracture table. We have to reduce the fracture, check in the C-arm whether the fracture is reduced or not in AP and lateral X-ray. These are the C-arm pictures are most important, and in this case you can see here there is some varus is appreciable in the AP, and in lateral view there is a posterior sac and anterior translation of the head neck fragment. This is one of the very good method, a Steinman pin reduction method. Intrafocally you have to put the Steinman pin at the fracture site and you try to manipulate the anterior and the lateral fragment so that we get a anteromedial proper reduction. After reduction, you fix the fracture from the lateral side anteromedially, and that Steinman pin should be away from the trajectory of nail insertion. We may use a 1 or 2 pins depending on the stability of the fracture pattern, because we need to adduct the fracture so that there should not be any displacement of a fracture at the fracture site. This is the most important shape. It is also called as a Steinman pin fixation, anteromedial fixation, and you can see, appreciate lateral side how it has been restored the angle. 5 centimeter incision is given superiorly of the greater trochanter, and then you can with the finger we have to palpate the tip of the trochanter. Entry guide wire is passed and checked in the C-arm. That is most important. It should be in the center and medial to the tip of the trochanter. You can appreciate here the guide wire is at the tip of the trochanter but slightly laterally placed. It's not desirable, so I have changed the entry point, and it is now it is in the medial to the tip of trochanter, and precisely you can say it is in the piriformis fossa. After the guide wire placement in AP and lateral checking, then we have to do a proximal sequential reaming. I don't use straightway 13 mm proximal reamer. I use first a 10 mm cannulated reamer so that it avoids the shattering of the proximal femur and greater trochanter, and then subsequently I use a 13 mm proximal reamer so that there is fragmentation of the trochanter is avoided. This is, you can see here how the guide wire is passed, and this is a 10 mm first a proximal reamer, and then you pass a 13 mm reamer for proximal reaming. After having done this thing, we have to check again whether the guide wire translation has occurred on the medial or lateral side. This is most important. And the Steinman pin which we have passed anteromedially, there should not be any displacement, and we can check here how beautifully the reduction is there in anteromedial side, and there is a guide wire in the center of the femoral this femoral neck as well as in the shaft. After this, we have to assess the canal of the femur. In osteoporotic bone, most of the time the canal assessment, this reaming of the medullary canal of the shaft is not required. Insertion of the nail is done here. It is a 12 mm nail. Proximal diameter is 15.5, and we have to see the 2 aperture there should be aimed at inferior calcaire region. Insertion of the 2 guide wires, superior and inferior guide wires are passed, and they are also checked in the AP and lateral view. Inferior guide wire should be near the inferior border of the, or you can see near the calcaire. After drilling of the inferior screw, then we have to check in AP and lateral X-ray and incision for plate, because after putting the shoe you cannot put the plate, and you can appreciate here a coronal split, and through that coronal split there are a passing of a guide wire, that therefore the screw cannot give a stability to the fracture in the coronal split, and therefore failures are most of the time and you can see, appreciate here how there is a fragmentation of the greater trochanter. So in such a situation, it is always a failure of the nail, though in X-ray it looks very good. Now after passing the this is how you can see that you appreciate that the bare part of the proximal part of the nail. Now the plate is placed on the through that guide wires, and the through the jig the screws are passed to the stabilizing screw and inferior screw, so that the plate is now snugly fitting with the greater trochanter, so that this plate through this the screws through this plate not only fixes the head neck fragment but also buttresses the lateral wall. Now we have to fix the plate to the shaft, and in this actually it should be a machine technique. It's a machine distal locking is done, and then afterwards you can also do this is the jig is removed because it is very difficult to pass the screw when the jig is there. And then machine technique, screws are passed. Mostly it is anteriorly oblique screw, distally you can see here, and fixation of the plate and to the shaft is essential, so that it gives additional support to the nail in a fragmented trochanteric and coronal split. The distal fixation, and then we have to assess the stability whether it is inside or not, and fixation of the plate to the trochanter. 1 or 2 screws are passed. You can also augment this plate with stitch scissors like Ethibond, or you can also use a 18 mm gauze wire, or sometime fragmented, and you can see the stability of the screw, check it, and closure of the wound. This is again, before you close the wound, you must check it with the AP and lateral picture, how beautifully nicely the lateral part of the trochanter is buttressed. Everything will heal around the nail and plate, and this is the post-operative X-ray. So you can use 2 screw system, or you can also use a 1 screw system, and this is one of the paper. Trochanter is placed combined with the proximal femoral nail for unstable intertrochanteric fracture. Dr. Sasikant Ganjale from Solapur, he is promoting this method. I also most advocate this method, and majority of the surgeon all over the country now adopting to
with a chest support so that the patient will not fall on this side. This is the lateral view of the hip. This is the positioned on orthopedic table with a chest support so that the patient will not fall on this side. This is the lateral view of the hip. This is the AP view for the hip, and the hip is placed eccentrically against the normal side ischial tuberosity. There is a small pillow below the right buttock so that the patient will not come to the center. The leg is supported to have slight flexion at the knee joint. Shoot. I am percutaneously passing the cavern, hitting the lateral cortex, slipping in front, slightly withdrawing below, and taking a purchase in the anterolateral part. Shoot. Okay. Lateral. Now, in the lateral picture, I have confirmed that it is going anteriorly. Shoot. Save. And shoot. Save. Another wire about a finger breadth or about 1 centimeter. Again pass in similar fashion, fixing the fracture. Shoot. It was going very in the center. Shoot. Shoot. Save. Now the fracture is fixed in reduced position with 2 KYs. Now we will adduct the limb. You can see that we are adducting adun today. Okay. Now the life of working from here becomes easy. This is the anterior superior iliac spine. This is the tip of the trochanter. A line from the anterior superior iliac spine and one along the shaft. Wherever they meet, take the incision at the junction toward the tip of the trochanter. This is about 1 inch long incision. Start. Artery forceps is inserted and its position is confirmed. Shoot. That is on the neck and it is open and finger is inserted to feel the tip of the trochanter and the fossa medial to it. Yes. 3 millimeter long guide wire is taken and inserted under CM control. Shoot. Very well placed in AP lateral. I will exchange the stiff guide pin with a flexible guide wire by passing this. Shoot. With the help of this, you can get the guide wire position wherever you want. Shoot. I am happy with the position now. I can go still laterally. Shoot and save. Long guide wire. Long guide wire is fast. This is another useful instrument. You can pass over the guide wire and take out the bone from the medial aspect from the neck. Shoot. Shoot. Save. Slotted hammer. I'll pass the protector sleeve, and through the protector sleeve I'll pass the centering awl to ream for the proximal enlarged portion of the nail. Again I am keeping a pressure on the medial aspect so that I will be reaming more on the medial side. Shoot, save. There is a stopper here that will give an idea where to stop. Now the work of reaming is over, and I'll pass the nail, so I'll be removing the sleeve, protector sleeve. Selected a TFN of 11 millimeter, and I am while passing the nail, it's better to adduct and flex the hip so that nail passes easily, otherwise it will touch the medial cortex. Now the work of the guide wire is over. I am removing the guide wire. I apply the extractor rod for final seating purpose.
Start.
Shoot. 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 Okay. The assistant will keep a constant pressure so that the nail is properly positioned.
Yes.
So now this is the distalmost hole. I will take an incision for both the neck screws, and I'll pass the trocar, and over the trocar I am passing the shoot, save, guide wire, guide wire.
Yes.
Now I'll pass the guide wire. This gives an idea about the direction of the sleeve, the jig in the lateral view. Shoot. Okay.
Start, sir.
Now for passing the superior derotational guide wire.
Yes, starts.
Guide wire sleeve. Shoot. Okay. Shoot. Save. Now this is the step cut drill for the derotational screw. I normally prefer to use with the hand. The reason is this patient is an 85-year-old lady, so either by 2 or 4 motion or in the reverse rotation I ream them so that the bone gets compacted on either side. Shoot. While removing, I am removing anti-clockwise so that not come along with this. Selected the desired screw of 75 millimeter.
Start.
Now for the inferior, I'll put the 8 millimeters the superior thinner step cut drill and the sleeve for the same, and again by hand reaming by to and fro motion on either side, I ream, shoot.
Yes, sir.
Now I am removing the step cut drill and the sleeve. Use the larger step cut drill only to open the lateral cortex. Shoot. Okay.
Yes. Yes.
This is the 85 millimeter, 8 millimeter cervical screw I have selected. It has got good purchase because we are not removed too much of bone. Shoot. Okay.
Start.
Now the traction is released from the foot end. Now I'll compress the fracture once again, and I'll compress alternatively superior and the inferior screw. Okay.
Yes. That's it.
Now I am doing the distal dynamic locking. Again, I use the trocar to mark knife. A small incision is taken which can accommodate the sleeve. The trocar is passed first. Over that the sleeve is threaded. Sorry. बस this is 38 millimeter bolt. Okay. Now I'll remove the jig and finally see the images on table. Text करा था.
हाँ.
Entry wound. These are the wound at the end of closure, the entry site, the neck screw, distal locking. Left side is operated one. We have applied compression bandage to both sides to prevent DVT, and this compression bandage also prevents collection happening at the entry site. 2, 3, 4, 5 खाली गया. परत 1 मोजा 1 2 3 4 5. Okay.
Good evening, everyone. At the outset, I am delighted to thank all of you, members, guests, supporters, residents, fellows, who joined today's first day, which was the virtual day of Wiroc Max 2022. From tomorrow onwards, that is 29 December 22, we'll be starting the physical part of the Wiroc Max at the Geo World Convention Center. We start at 8:50 a.m. in the morning. Hope to see you at the conference venue in person, and hope you all had enjoyed today's surgeries which were served to you on the platter. This site will be working for the next 4 days, that is till the midnight of 31st December 2022. Until then, you can enjoy the various surgical videos which have been uploaded on the site. So see you soon. Bye-bye. And on the behalf of the organizing team of Wiroc Max 2022, I thank Ortho TV, Dr. Ashok Shyam, Dr. Neeraj Bidlani for arranging such a wonderful show, and also thank Dr. Michelle Parikh and Agnivesh Tikku, the webmasters of Bombay Orthopaedic Society, for sparing their day and making it happen. So see you tomorrow back in action at the Geo World Convention Center from 8:15 a.m. onwards. Till then, bye-bye from Team Wiroc Max.
Thanks. Ending the stream.
Thank you.